Hello, everyone, and welcome to ASCO's Online Clinical Educators Forum. My name is LaShawn Sidbury, and I'm the Director of Meetings and Special Interest Groups at ASCO. Before we get started, I would like to go over a few items so you'll know how to participate in today's event. We've taken a screenshot of the attendee interface. You should see something on your screen that looks something like this. In the upper right corner of your own computer's desktop, there's an orange button which allows you to minimize and expand the view of your own control panel. When you join today's webinar, you selected to join by phone call or computer audio in listen-only mode. If for some reason you would like to change your selection, you can do so by accessing your audio pane in your control panel. Those participating in Canada may need to click on other numbers to find the dial-in number for your country. If you have any questions during the presentation, please type them in the questions pane of the control panel. Session moderators will bring them up during Q&A, which is at the end of each session. Please also use the questions box to let us know if you're experiencing any technical difficulties. We have Sarah Lau, ASCO's Business Operations Manager, and Alex Job, GoToWebinar's Technical Specialist, joining me to provide the best possible technical assistance during the event. I would now like to hand the session over to Dr. Joshua Baker, who's the Dean of Midwestern University, Arizona College of Optometry, and Chair of ASCO's Clinical Affairs Committee.
Good morning, everyone, and welcome to the 4th Online Clinical Educators Forum. I'm Dr. Baker, Chair of the ASCO Clinical Affairs Committee. This committee has brought you this forum through the generous support of the ASCO Clinic Directors Administrator SIG. We're going to acknowledge the entire CAC committee at the end of the program, but before we start, I would like to thank our planning group chairs and moderators, Dr. Stephanie Klemenchik, Dr. Maria Parisi, and Dr. Neil Pence. And thank you to the rest of our working group members, Dr. Tom Landgraf, Dr. Beth Steele, and Dr. Kayla Motherly. Finally, I'd also like to thank two people who have been instrumental in bringing the forum to you today. Thank you to Mrs. Carol Brubaker and Ms. LaShawn Sidbury, liaisons to ASCO. They've kept us on track, and without them, we have not been able to deliver this program today. Many thanks to both of you. Just some quick housekeeping notes. If you are watching as part of a group, please make sure that you have each attendee sign an attendance sheet. This is really important because it helps us when we look for financial support for future programs. At the end of this program, the institutional liaison should send the attendance sheets to Carol Brubaker at cbrubaker@opted.org. Also, at the end of the event, please go to our SurveyMonkey evaluation link and take our survey so we can assess what we've done today and utilize the information for future plannings for future OCF. We have 3 sessions prepared for you today, and each one will move quickly. Each section has its own moderator, so without further ado, I'd like to introduce the moderator for the first session, Clinical Updates, Dr. Stephanie Klemenchik from the Illinois College of Optometry.
Thanks, Dr. Baker. It's challenging enough to stay up to date with the latest and greatest within your own area of interest, much less within all areas of interest in eye care. So we put together 4 short clinical updates on a variety of topics today. We'll be hearing from, first, Dr. Sheila Morrison from University of Houston College of Optometry. Dr. Morrison will be presenting a myopia control update. We also have Dr. Karen Squire from Southern College of Optometry. Dr. Squire will be updating us on low vision technology and specifically smartphones and the visually impaired. Dr. Casey Hom from University of St. Louis, Missouri College of Optometry will provide us with an update on OCTA imaging. And finally, Dr. Mark Taub from Southern College of Optometry will be concluding the session with an update on acquired brain injury, a case-based approach. But please note, we have reserved time for questions at the end of the clinic update session. So that will be at the end after everyone has presented. Or if you need a break to stretch in between sessions, you can use the questions time for that as well. So here's just a little bit more information about me, but we'll go ahead and kick off the session with Dr. Morrison, a myopia control update. So I'm now going to turn it over to Dr. Morrison.
Great, we're ready to go. Hi, everybody. This is Sheila Morrison here. And currently I'm on faculty at the University of Houston College of Optometry, and I'd like to thank you for having me here today. I'm honored to be able to represent our college and our team of faculty in a clinical update on myopia control. Now, in the constraints for time within this short webinar, I've selected a few highlights to provide to educators, and my goal is to make sure that we are all on the same page about these important topics, because there are common questions that we all need to know the answers to. In academia, we often go deep and become very focused on technical details of things that we know as optometrists and educators. My format in this update is aimed to meet a functional need we all have in the clinic, to simplify when incorporating myopia control into clinical practice and when dealing with patients. Now, our current state of affairs includes these questions, but is certainly not limited to them. Today's short list looks at the prevalence of myopia today. We need to be well-informed and confident in explaining why we care about increasing myopia in children. The parents of these children want to be informed and guided about the importance or lack of importance in slowing or halting progression of myopia and what the solution is to this problem. The mechanism behind myopic progression remains a highly asked question, as well as what the treatments are for myopia control, and specifically which of these treatments are the most effective. Finally, we're commonly faced with questions about how to explain these treatments and their safety to parents and patients. Now, we hear all about the myopia epidemic in academia, and reality is that parents of myopic children will actually come into our clinics with a range of knowledge in the area of myopia and its epidemiology. Some may have knowledge about the history of myopia and how we view that it's progressing, some may not. And I'd actually say that the patient education story should start with the basics of what myopia is, broken down, which is difficulty seeing things far away due to an eye that grows too long, very simply put. We can then say to parents with confidence that the prevalence of myopia has increased significantly over the past several decades. Now, the next question we'll be asked is really, why should we care? For academics and clinicians, why should we implement myopia control clinics, and why should we teach myopia control practices to our students? With the reported increase in myopia, parents need to be informed of reasons beyond inconvenience of wearing spectacle correction. And as doctors and educators, we do need to have a common understanding of and be familiar with and buy into the significant consequences of progressive myopia. In addition to pathologic complications that can lead to blindness, such as retinal detachment, glaucoma, and macular disease, we also need to consider the increasing cost of healthcare and the fact that greater refractive error may negatively impact the quality of life in our patients. Now, when it comes to understanding the culprit behind myopia progression, the jury is truly still out. More work is needed to understand this mechanism and likely the possible mechanisms regulating eye growth. Treatment with contact lenses for myopia control is currently the most commonly accepted modality. And the theory that best explains how this treatment works is the Defocus Theory. Based on the Defocus Theory, while traditional single vision glasses or contact lenses were the only option, we now know from work done by our peer-reviewed researchers that this may actually encourage the eye to grow longer. Now, on the top left, you can see that with traditional spectacle correction, we induce rays focused on that central retina, but behind the peripheral retina. The correct terminology to describe this, as we all know, of course, is hyperopic defocus in the periphery, which we also know to be a signal for eye growth. Now, the opposite effect is what we use in myopia control practice with contact lenses, called myopic peripheral defocus. This peripheral myopic defocus is a stop signal for eye growth. Now, with any of the myopia control refractive treatments that we prescribe for patients, the goal is always still to provide clear single central vision with central light rays focused on the retina. Now, the contact lens design that will achieve this is a center distance design. One thing we need to consider both in academia and in private practices is the fact that currently treatments for myopia control are not FDA approved. This becomes important to all of us when advertising a myopia control clinic and treatment, because it is not really appropriate at this time to state that the following treatment is indicated for myopia control in electronic or text communication on websites or in myopia control brochures, for example, in your clinics. And that's because these treatments are all still considered off-label use at this time. Now, parents, speaking of treatments, will often come to you with questions in the clinic. So your goal is to get the patient and the parent into the clinic through whatever ways that you reach out in the community and educate that myopia is an issue, and we have some solutions to help you with this. We want to bring the patients into the clinic, and at that time, we can talk a little bit more in detail with the parents about what the treatments for myopia control are. Oftentimes, these parents will come to you with an idea themselves from internet research or from word of mouth. And when we move forward, we need to be clear in setting expectations. So in education in the clinic, we explain that the reality is that we can't fully stop or reverse myopia in children, but we can slow the progression of myopia in most children using pharmaceuticals, multifocal soft contact lenses, and orthokeratology lenses. Now, you may be asked about, different pharmaceuticals such as pirenzepine. Parents may find this on the internet, and which has been shown to have some effect, but is not approved in the U.S. And that is why this slide lists atropine only, which is the most widely recognized pharmaceutical intervention and is available for use in the U.S. Regarding atropine treatment, no current study has been a randomized clinical trial looking at the effect on axial length between atropine and a control, though we do have new studies coming out in our academic circles. Now, in the myopia control clinic, you'll often be faced with the decision of what treatment to prescribe. And this is a very important question. If a contact lens option is selected, parents will want to know which option is more effective between orthokeratology and soft multifocal lenses. Now, there are certainly limitations to what we know in regards to studies. For example, only center distance studies have been reported. In our current literature, studies are typically only about 2 years in length. And we do know as academics that there is a need to follow subjects for more years in a randomized clinical trial setting. Now, that being said, currently the efficacy of these two contact lens options is approximately equal, as both Ortho-K and the soft multifocal designs have a combined reported treatment effect of about 40 to 50% reduction of myopic progression. Now, we still tend to go to orthokeratology first in clinical practice and then soft multifocal second. However, one thing to remember is that with currently available orthokeratology lens designs, low myopes might not get as much treatment effect, for example, as what could be achieved with the soft center distance multifocal contact lenses. We are working at creating different lens designs. Lens designs are being developed that may be able to achieve adequate peripheral myopic defocus for myopia control in the lower myopes. However, at times we may choose to use a soft multifocal in a lower myopic patient. Now, if candidacy is the same between orthokeratology and soft multifocals, then the next step would be to start looking very closely at lifestyle factors in these patients. Now, the bifocal lenses, the nearsighted kids study, is one that a lot of us are very familiar with, otherwise known as the BLINK study, is an example of an NIH-funded ongoing clinical trial being conducted at the University of Houston and the Ohio State University. The study is looking at the efficacy of commercially available center distance soft multifocal contact lenses on the reduction of myopia progression. The study is also looking at which ad power would be the most ideal, which is actually very important to us because at this time, we tend to, practitioners will use a variety of ads. Usually we think higher is better, and most of us settle at around about a +250 or +3. Now, the primary outcome in this study is the change in myopia as measured by cycloplegic autorefraction, but there are other secondary outcomes, including peripheral defocus while wearing contact lenses at distance and near, peripheral refractive error without a contact lens, and central and peripheral eye length. Now, studies like this are delivering very important information to eye care providers. For example, the BLINK study recently reported results on more than 300 children, demonstrating that with an appropriate minus overrefraction to optimize vision, the +250 ad multifocal contact lens being used in the study did provide adequate acuity that was not much different from spectacle correction. Now, studies like this can, of course, help to answer the common clinical questions. And another thing that's come out that we utilize in the clinic all the time is the fact that in a lot of these patients, over-minusing is often required to provide that adequate distance visual acuity. Even up to a minus 150 is what the study says. So don't be afraid to give a little bit of extra minus in your myopia control soft lens patient. Now, this slide contains simple statements. So kind of to go back to my mission of how do we simplify when we're explaining this concept to patients and parents. So this is examples of easy ways to answer the questions we're faced with from parents, which is, how do these treatments work to slow my child's myopia progression? Now, again, as optometrists and optometry educators, we pull apart details and we look closely at ophthalmic technicalities. And this is really important to us because our patients' vision and sometimes even their lives depend on us doing that. When it comes to educating patients and parents, at least initially, until we determine their education and knowledge level, it is extremely important to keep things simple in the myopia control clinic and not overwhelm them. Safety is definitely a consideration in myopia control clinics. Studies such as the CLAY study have looked at, which is a very significant impact study, has looked at the risk factors for use in contact lens wear. In the literature, there are reviews of such studies in recent publications, and overall, when we answer this question, are the treatments for myopia control safe in my child? We can explain to parents that the answer is yes, they are safe, but there are some risks to be aware of, such as things like mild inflammation, abrasions, blurry vision, microbial keratitis, for example, though the estimated rate of infection is not high. Now, the long-term effects of atropine treatment are still not fully understood, but generally we accept risks of use to include stinging, blurry vision, and light sensitivity. Overall, when used properly, the risks associated with myopia control treatment are thought to be lower compared to long-term risks of high myopia. Now, we have gained knowledge through the process of integrating myopia control into clinical practice and into educational curriculum. And the second section will highlight some very important action items that you will need to consider to ensure success in your myopia control clinic. Now, the number one priority is to provide evidence-based care. This means that we absolutely must be knowledgeable and up to date with the current literature related to myopia progression, etiology, treatment options, and efficacy. Now, the safety of these options and products available are also important for us to keep up to date on. Now, I've been really lucky enough to work with some of the world's leading researchers in myopia control, and an important responsibility that we all have is to support the initiatives of these groups through ongoing referrals to their studies, especially when in an academic setting. Now, the protocol for myopia control has yet to be established as a standard of care that is recognized by our optometric governing bodies, like the American Optometric Association or groups in other parts of the world. Within your college or private practice, it is very important to make sure every practitioner provides myopia control services in the same way, and this includes fees. At our university, there was a challenging transitional period at which time when we were implementing a more formalized myopia control model, it became very apparent that for years, prior clinicians had been providing myopia control services, but in all different ways and charging fees that were not always consistent, which definitely created a growing pain in trying to smooth that over into one unified clinic. However, now we're right on track. So, if you're just starting out, if you can establish that protocol that is consistent and the same across practitioners right from the start, it will make things go smoother for you in the long term. Now, when you do establish a protocol, beyond being evidence-based, which has got to be number one, you also need to consider what tests will be performed and when they will be performed. So the protocol should also include expecting testing for treatment visits and what is included in follow-up visits. Reality is at this time that the actual protocol may vary slightly by school or faculty preferences. But again, within your clinic, it's very important that everybody agrees to this single protocol. Now, myopia control is a specialty service, and it's just very similar to specialty contact lens practices. Our low vision, we all have tools that we need to invest in order to provide the care that's required for the specialty service that we're offering. Now, currently, the standard of care to monitor myopia progression is axial length of the eye. And the two types of equipment that would be best indicated in a myopia control practice are the LensStar or IOL master. Now, typically, ultrasound is not usually repeatable enough for what we would like, so we would prefer utilizing one of the prior pieces of equipment that I just mentioned. Now, corneal topography is really, in our perspective, a must for orthokeratology, also a great practice for soft contact lens practice. And finally, an open field autorefractor would be preferable in a myopia control clinic. But since the patients are usually cycloplegic, which will relax the accommodation, a closed field is acceptable in some cases. Now, the protocol should also state how many measures you take with each piece of equipment and what the expected acceptable variability is in each of these tools. Now, we talked a little bit earlier about the FDA and off-label use of myopia control treatments. Not only are the treatments considered off-label use, but myopia control is actually not recognized or covered by insurance in most cases. So, as you're setting out your clinic or implementing new procedures in the clinic, many myopia control practices will initially contemplate whether it makes more sense to bill for individual procedures and submit to insurance for some parts, and for others not, or charge a cash global fee. Now, what ends up happening in most cases where insurance is billed in part for myopia control services is that the patient leaves, claim is rejected because it's not recognized by insurance, and it may become very difficult or cumbersome to collect these fees. And it's also confusing and frustrating for patients to be faced with unexpected balances owing after the fact. Myopia control, as we said before, does require special testing and expertise, and it should be billed accordingly. The most effective strategy for fees really is to charge a global cash fee, and then it will have to be decided in your practices and institutions if this annual fee covers any follow-ups or if follow-ups are extra. It's recommended also that materials and drug costs, such as contact lens fitting fees and materials, are charged separately from the myopia control clinic fees. Myopia control and treatments are definitely not an area of common knowledge. So it's also very worthwhile to spend the time creating educational materials through a website, as well as written educational materials. Now, creating the foundation in this area for successful and smoothly run clinic takes a lot of time. You have to put in the infrastructure. Posters, brochures can be used to outline myopia and the risks of progressive myopia. Remember, it is not advised to directly state that, for example, orthokeratology is a treatment for myopia control in a website or on print. Again, because it's off-label use. Written materials are great because they can be distributed to patients and students easily. What you see in this slide is an example of one side of a brochure that we would utilize to give to patients. It's very simple, goes through what is myopia, what are the risks associated with it. Now, the population we serve in the myopia control clinic is typically pediatrics and adolescents because we know that the target for myopia control is school-age myopic progression. Kids are in school, parents often work during regular business hours, and so to make the clinic fully accessible, we found that some evening or possibly even weekend hours should be available. Additionally, due to the need for a one-day follow-up first thing in the morning for new orthokeratology fits, morning appointments must also be available. And finally, continuity of care is a very important consideration, and this is strongly advised in a myopia control clinic, and whenever possible to have the same faculty or students available on the same days for the patients that return to the clinic. Myopia control being specialty is something that we certainly want patients to understand and feel the value of whenever they come in, especially for the first few appointments. Longer exam slots may ensure more doctor direct time, which parents appreciate. In an academic setting, these adequate time slots will also allow for more advanced training early on for students and residents. Now, staff must be educated so that when a patient calls in, they will feel like they have a competent specialty clinic. It may also be a good idea to dedicate a special staff member in the clinic to be the main point of contact for the myopia control clinic. This person is especially useful in triaging and answering more complex questions about billings and orders. Now, to get the clinic off the ground, especially in an academic setting, and in particular, if you're looking at extending evening or weekend hours, you may wish to offer hours outside of the normal clinic schedule, and this can be achieved very easily by taking student or resident volunteers at your colleges, which is a very good strategy. at the University of Houston, we started by offering one extended evening until about 7 or 8 p.m. And to see enough patients during that time and offer a good experience for our students, we did recruit fourth-year students and residents by offering a volunteer opportunity over email. Now, the responses flooded in, and the clinic has had no trouble generating student interest. And usually the students who do volunteer are keen and motivated to gain specialty training in myopia control, so it's just a win-win-win all around. Just as important as it is to stay current on literature and standards of care, it's very, very useful to get connected in the community of myopia control providers and associations. It's easy to become a member of, for example, the International Myopia Institute, and the website is on this slide for you. And there are also more educational meetings for doctors with sections devoted solely to myopia control and treatment options. It's been my honor to be included in this forum, and I just want to thank the ASCO Clinical Affairs Committee and Forum Planning Group for inviting me to speak today. I also want to acknowledge my colleagues at the University of Houston and recognize Catherine Richdale, who is currently the faculty member offering expertise and extended hours here in our clinic. And now I'll hand it over to Dr. Squire.
All right, thank you, Dr. Morrison, for a lot of information about myopia control. I am Dr. Karen Squire. I work at Southern College of Optometry, and I work primarily in the low vision clinic. And today we're going to talk a little bit about apps that are available and kind of ways to adapt your smartphones for patients that have visual impairments. So back in 1995, Angela Bennett was one of the characters in a movie called The Net. And she has a very famous line in that movie, well, probably the famous line in that movie, "Our whole lives are on the computer." Here in 2018, she might change that, that line to be, "Our whole lives are on our cell phones." And with some simple modifications and some changes to your smartphone accessibility options, we can also extend that same thing to our patients who have visual impairments to make sure they're able to use the device just as successfully as we do. Back in 1994, the first smartphone came out. It was called the Simon. It was $899, which at the time was pretty significant for a cost of a smartphone. It would allow the user to dial out, to send an email, and faxes. Back in the day, we used faxes a lot more than we do now. The one app that was available was close to $3,000. So needless to say that the Simon did not really take off and didn't become a popular device such as the smartphones that we use today. Back in 2007, Apple first released its first smartphone, the iPhone, at a much less prohibitive cost at $499. And apps ranged really from free all the way up to about $30, up to $50. It was a lot more accessible for people to extend the range of what that phone was able to do beyond just kind of what the initial Simon was allowing for. So people could use this for emails, for texting, and a lot more ways to kind of get some enjoyment and entertainment out of our smartphones. When we talk about smartphones, we have to kind of include other types of consumer technology, things like computers, tablets, but today we're going to be looking more on how to focus and adjusting our smartphones for patients with low vision. The way that we kind of approach smartphones for our patients that have visual impairments is we use traditional low vision concepts and combine that with technology. So things like making things bigger, enhancing contrast are simple things that we can do for our consumer technology to get more use for our patients that have visual impairments. There's a shift from using a traditional low vision device like a magnifier or even a video magnifier to adapt for vision loss. And so by doing this kind of on one object and one device versus using several devices, we kind of help our patient consolidate how many low vision devices they have and lower the collection of devices they have at home. It also helps with lowering the financial burden. A lot of times with patients, especially with progressive vision loss, they have to continue to get new devices or new resources, and that can be very expensive for patients. So by using one device that does many things, that's a great way to kind of help our patients kind of save a little bit of money so they're not having to get new devices at such a significant cost. When we're introducing the idea of a smartphone to a patient, we have to take into consideration the patient's age. How younger patients accept technology and older patients accept technology is a little bit different, and there can be some adjustments to how we introduce how a smartphone may be helpful for those individuals. For our younger patients, they're a lot quicker to pick up technology. They are very in tune with using different types of devices, much quicker than I am for sure. And a lot of our younger patients, instead of using something like a handbook, they're going to use just trial and error. If something doesn't work, they'll keep working at it until they can figure out how something works. A lot of our younger patients too also like to follow trends. So you'll hear sometimes somebody having an Apple phone, and then next time they have a Samsung, just because that's the trend of what device has the best technology and is the coolest thing to use. And with our younger patients, technology has just always been a part of growing up, which is different from some of our older patients. Our older patients, a lot of the technology devices that we're using kind of replace previous devices that were used. Our smartphones are replacing landlines, and that's something that our older patients sometimes have a little bit of challenge making that adjustment from one to the other. Our older patients too typically prefer something like a handbook or written directions. When you think about when you get your new Apple phone out of the box, you have to hook it up to iTunes or hook it up to a computer. And it doesn't really have written directions. It doesn't really have ways to kind of show you how to mitigate using that new device. You kind of have to practice with it. With our older patients, there's a few things to also keep in mind too. We have a lot of individuals, our aging population is also showing an increase in visual impairment, so we have to kind of consider that some of our patients in low vision clinic are older individuals. We want to kind of look at how they might perceive something like using a smartphone. The perception of a smartphone from a lot of older people is just that they're a lot safer than traditional phones. They're a lot more useful because they can do a lot of different things. There's also another expectation too that people that are older that use smartphones thinks everybody else has one too, and that's not always the case, but there's just that kind of perception. It's just a common use amongst everyone. For our older patients to continue to use a smartphone, it has to be fun, it has to build confidence, something that makes somebody feel less confident in their abilities and works against their self-esteem. They may kind of abandon the use of the device. The continued use, if they can see how the safety features are helpful, then somebody's going to be more likely to continue to use it. And just information and communication, the extended range of what a smartphone can offer to someone is very helpful for somebody to continue to use that device. The last thing that kind of helps people keep in use of a device is training. If you can show somebody how to use a device to the best of their abilities, they're more likely to continue to use it. If you don't know how a certain app might be adapted or how to turn things on or get the thing to turn off, there are some barriers to usage, of course. We want to make sure that we train our patients, make sure that they're comfortable with using it. Some of the obstacles for successful use is lack of support. When somebody gets a smartphone and they bring it home, having somebody in the family that can continue to kind of work with the training, make sure that somebody knows how to use it, or if something goes wrong, how do you fix it? Also, too, sometimes that benefit that they thought was they would get from the smartphone isn't always necessarily there. So sometimes that perceived benefit doesn't actually meet reality, and that might be a reason somebody abandons their device. A lot of people do feel sometimes technology is too complicated, and that can be a little bit of a challenge for continued use as well. And also the size of the device. A lot of people still kind of fight the size of an iPhone, even though they get bigger and then they get smaller. Sometimes the size of the phone itself can actually be a little bit of a challenge as well. Accessibility in smartphones has changed dramatically over the years, and the use of apps that kind of can help with people who have visual impairment has also increased significantly. There's a lot more focus on research and development on accessibility options for things like apps or even the phones themselves. When polled, a lot of people who are visually impaired, 83.1% of people who have used smartphones thinks that apps have become more accessible over the years. So people who are visually impaired are also noticing an improvement rather than just kind of saying that there is an improvement in what's available. A lot of apps now kind of replace standalone technology. Things like GPS apps can replace that GPS system that you used to have on your dashboard. Everything's built into the phone, and that's a great thing for a lot of our patients. Also, usually people that are using iPhones or smartphones for visual impaired technology, most of them are using Apple technology versus Android. And I think that's just kind of a skew and kind of what's available at this time in apps. A lot of apps are first available through the smartphone through the Apple technology. And app use it's mostly dependent on the person themselves. There's not really an age gap or an income level that kind of precludes somebody from using the app. It's just kind of depending on what that person would like to use. So there's a lot of features that are kind of built into smartphones that we're going to take a quick look at. There's a group of doctors from outside of Chicago back in 2012 that polled their visually impaired patients to see, are they really using their smartphones? And at that point, only about 24% of people were using smartphones. The most common options that were available were text, email, and internet. Now in 2017, over 95% of visually impaired people are using smartphones. And there's a wider range of what people are using their smartphones for. Emails, of course, are still the most popular, but other apps are kind of allowing people to use the smartphones for other types of activities. So each phone, whether it's an Apple phone or if it's an Android or anything that has a smartphone technology, usually has accessibility features built right into it. When you open up the general settings on your iPhone or on your Android, you're going to see a tab for accessibility. When you click on that, it is going to bring you a whole new menu of options and ways to extend the range and use of your smartphone for visual impairment and also other types of disabilities that you may have. Some of the apps are a little bit difficult to get in and out of, so in those situations, you can use Siri to turn apps on. VoiceOver is probably one of the more difficult ones to navigate, so I usually recommend that patients just use Siri to turn the app for VoiceOver on and then turn it off when they're not going to be able to use it or not needing to use it. There's a lot of features that are available. Not everybody who's visually impaired is going to use every single accessibility option that's available. Most of the accessibility features that are available are more at visual enhancement. So things like zoom, which is a magnification feature, which I'll show you in a couple minutes. Large text, which enlarges the text, not just into your texting and emails, but also throughout the entire phone. Invert colors is a great way to enhance your contrast. I'm going to show you that one in a couple minutes too. The ways to kind of convert your phone into an auditory device, things like VoiceOver and speech selection, aren't quite as commonly used. But I think it's also they're a little bit more difficult to kind of get in and out of. And so with training, I think those types of features would be a little bit more readily used. So first, we're going to take a look at the large text capability. We have a little video here to kind of show you what using your smartphone for the large text. You can kind of slide and scroll across to make sure that you can extend the capability of the large text. When you do that, your contacts are going to be large print, so that makes it a lot easier to see those smaller text. That smaller text, that can be a little bit of a challenge. It's also going to extend the range of your text messages as well, so that print will be large. If we were to go into our email print will be large as well. So it kind of goes across all different layers and capabilities anytime you may run into print. You can also add and filter to that as well to make the contrast a little bit more vibrant. Another way that we can enhance vision with the use of a smartphone is using invert colors. So by inverting colors, what we can do is we can, once we have that open up in our accessibility menu, in an opposite fashion. When that happens, the good news is your text will kind of flip backwards. You have less glare coming from the screen, but your photos and your images will kind of have an opposite color, similar to what a film. And on to our next video. The smart colors, this option is going to just convert the white background into black, and it's going to leave all of your images and photos the real color, so you don't have that opposite film negative effect. So a little bit more better use for that. The next app that we're going to take, next accessibility option, is going to be called Zoom. This is going to magnify the screen over all the apps that would be used. What this accessibility option can do is it can magnify past the platforms of what Facebook and Instagram can do and allow you to kind of get into a lot of the different apps and get a little bit more visual information. So, oops, there's the video. And so just by using some hand gestures, or there's a little control panel that can be used as well, You can slide and extend the range of magnification, and that will be extended across all your apps that you would be using. So things like Facebook or Instagram, if you have your banking apps on your phone, that can be used as well. Okay. So on to the next thing is we have a few apps to take a look at. With a lot of apps, we do things that kind of help replace other standalone devices. One issue that patients may kind of have an issue with is reading money. Money typically has very low contrast and the print isn't always so great. So by using an app that was developed from the Bureau of Engraving and Printing, Apple was able to develop an app that would help people be able to read money much more quicker and much more efficiently. Once the app is open, that's kind of what this screen is looking at here. What it will do is it will just read aloud the denomination of that print. It doesn't have to be lined up perfectly. It only has to be about 50% of the bill, and it will read aloud what that banknote would be. So it's very helpful for people who have a hard time sorting money if they're in an area where they don't have somebody where they can ask for assistance for. So it's a very quick and easy app to be able to use, and it's also free. Another very popular app is called TapTapSee, and what it does, what this app does, it's free, which is great, but it works for either iPhone or Android. What it does when the app is open, the camera is going to take a picture of an object of interest that a patient may want to see. So something like a soup label or a spice, that's going to be helpful for them to be able to get information about what that is. What happens when that picture is taken, it's uploaded to either using a computer generation source or using crowdsourcing to quickly and efficiently identify what that object is. So you get an auditory readout of what that object of interest would be. So if you had a question about what that soup label was, it would allow you to, it would be uploaded to the crowdsourcing center, and then somebody would actually read aloud what that's going to be. So with this app here, how this works is you find an object of interest. When the app is open, oops, I think this is not going to work quite so easily, so we'll skip over this video because it looks like it's stuck. What happens here, I'll make it a little bit quicker, is find the item of interest. You just touch the center of the screen. It's going to upload it. We'll tell you the picture's in progress, and it's going to give you a readout at the bottom of what that object of interest is. Depending on who's on the other side of that upload, you may get very specific information like a white ceramic pig figurine, or it can go into a lot more detail. So there is variability based on how much information that person that's working with you is going to be able to give you. It's great to use. It's a very easy app to use. You don't have to have a lot of dexterity because once the app is open, you just have to tap in anywhere in the middle of the screen. There is a little bit of a disadvantage because there's some variability in how much time it takes to get a response. It could be 5 seconds or 10, so depending on how stressful of a situation you're in, you might have a little bit of a delay, and that might be a little bit difficult to kind of ameliorate. The other thing is when the app is open, the camera is always searching. So it's always going to be activating that camera so it can quickly wear down your battery and be difficult to get much use out of your phone when that's on. The KNFB Reader is another great app. It's an optical character recognition. So once it takes a picture of a document, it can convert that visual information into an auditory format. It can also turn it into Braille as well. It can read about 20 different languages, which is great. A lot of apps are getting a little bit wider in their use. The other nice thing about the KNFB Reader is that it does not need an internet connection, so it can be used as a standalone as is, and it's a great app for people who maybe potentially have a reading disorder, maybe they're unable to read efficiently, maybe they have dyslexia. It converts everything into an auditory format so they can keep up with their school and their classwork. Color identifier, this is it's called Inspector. There's a lot of these that are available. When the color identifier is open, it's just going to pass over an object of interest and read aloud what the color is that it's looking for. People who have visual impairment sometimes can't see color, so this helps them kind of adapt and kind of figure out what colors, and putting together an outfit allows somebody to get a little bit more information about the colors that they're looking at. This is very important just for self-grooming and making sure that when you leave the house that your clothes match and you look as great as you want to look. So it's a good thing to show to patients who do have color vision issues. Be My Eyes, this is one that's this is an app that's been in the news quite a bit. This uses crowdsourcing. So somebody who's visually impaired would download this app, and they would be connected to somebody who's normally sighted. So if there were a question that somebody were to have, maybe they lost something on their desk, or maybe they were looking at a spice and they had a hard time finding information, what they would do is they would access the app, they would take a picture of what they wanted to get information about, and they would be put in touch with somebody who's normally sighted. So there's volunteers who actually will ask to be available, so should somebody have any questions or issues, they have somebody there for them to be able to talk to. It's almost like having somebody right next to you, and it's a free and easy app to use, and it's become very popular across the world. Just have a couple more things to look at. Seeing AI is probably one of the more common apps that people are using these days. It's very, very popular with people who are visually impaired, and it's also very popular with third-year optometry students once they find out what this device can do. What this what this app does, it uses artificial intelligence. So it's actually going to create a computer-generated report on what it sees and kind of create an image, create information for that person who's visually impaired to be able to use it. It does a lot of different things. It can do anything from facial recognition to reading money. And one of the great things it does is handwriting reader as well. So the barcode reader is one option that's available, also to facial recognition. If you are unable to read somebody's face or see somebody's face, when this app is open, it will find somebody in the room and it will give you a description. Some things may not be accurate, kind of hear about the age may be off or by a little bit, but it will give you a description of what that person looks like. You can also go in and label the person's face. So anytime the camera passes over that person's face in a room, it will read it aloud, which is a very great feature for people who have a hard time recognizing faces. Other things that Seeing AI can do, or they can do a scene description. So you can kind of see the layout of a room. It will can just generate a small report of what is actually in the picture. Also to a document reader, and just like our KNFB reader, it can either take a picture of a document or even take a picture of a sign and read aloud what the object is. So we take a picture of the van. Oh, goodness gracious. Take a picture of the van, and we are going to get, there we go. We're going to get information kind of written in a printed format, and if we were to press play down here, it would read that aloud. The last feature that Seeing AI does, and I'm trying to, hopefully this video works, is a handwriting reader, and this is the only device that's available currently that can actually read handwriting. Oops. Let's see if that works, and if it doesn't, there we go. So just once you activate the app, you click the handwriting reader, tap on the screen, and then it will then read aloud what your kind of information that you're looking for. So it's a very helpful thing for people who write lists or have a hard time reading other people's handwriting. It's a great feature that's available. So thank you very much for your attention. And at this time, I'm going to hand this over to Dr. Hom.
Thank you, Dr. Squire. Good afternoon, everyone. Thank you all for joining us. I'm Casey Hom, and I'm going to be providing a clinical update on OCTA imaging. I'm on faculty here at UMSL in St. Louis, and I have no financial disclosures to report. So let's start by looking at a timeline of OCT technology. The very first utilization of OCT to image living tissue was within the eye with retinal imaging in 1993. Time domain OCT became commercially available through Zeiss in 96, and 10 years later, we got the much higher resolution spectral domain OCT hitting the market. OCT angiography just became FDA approved in the US in 2014, so this is definitely still a new technology. OCTA works through what's called motion contrast imaging. So we're taking many B scans of the same area, and it's assumed that the retinal tissue itself is going to remain stationary. So the only changes in the signal from scan to scan are from the flow of blood cells through the vasculature. So depending on the instrument, different algorithms are used in order to take this changing information and calculate it into a 3D image. We can also get different parameters from the info. So we can calculate things like vessel density, which is the % of detected vessel area out of the total image area, and flow index, which is a parameter representing the average change or decorrelation in the signal and is proportional to velocity of the blood flow. OCTA instruments that we have available today in the US are just the OptoView AngioView, and then the Zeiss AngioPlex. There's definitely some other ones out there, but they're just not yet available here. We have our NIDEC, our Heidelberg OCTA, as well as the Topcon, and the special part about the Topcon is that it's using swept source technology, whereas the other ones are still spectral domain. So Topcon is going to be even higher resolution, even faster image acquisition. And all of these different instruments have clinical cases and image galleries on their websites, so that's something interesting to check out or to be able to point students towards. So which system is best? Several studies have looked at this. One in 2016 directly compared Zeiss with OptoView OCTA, and they did find that the Zeiss AngioPlex had shorter image acquisition time and a higher percentage of reliable images with fewer motion artifacts. The next year, the comparison, the Topcon and the Heidelberg were added to the mix, just the prototypes here. And this study found no significant difference in motion artifacts. However, when taking several different imaging characteristics into account, Zeiss was ranked #1 with OptoView coming in second. But really they concluded it depends on the specific parameter being evaluated, and every model does have its strengths. Here at UMSL, we have the Zeiss Cirrus with AngioPlex. So here's an example analysis printout, and you can see we're able to view all of the retinal layers one on top of the other, but you can also segment out with these preset segmentations of the different vascular layers. So we know that the vitreoretinal interface, or VRI, as well as the avascular or photoreceptor layer should be devoid of vessels in the absence of neovascularization. We're able to visualize the foveal avascular zone, both in the superficial and deep capillary plexus layer. We can also look at the choriocapillaris and choroid segments, both of which should be very homogeneous in appearance if the eye is normal. We have our structural en face image correlating over to the right. And then down below, you'll notice we have our B-scan cross-sectional image, which is actually color-coded for flow. So red is retinal blood flow, and green is choroidal. So higher amounts of color signify there's greater blood flow in that area. And here's the en face image that comes along with just taking that scan. So this can just help to correlate vasculature with any other findings in the area, but this scan is definitely less utilized. Here we're looking at fluorescein angiography compared to OCT angiography. And this is a patient, this study was looking at an ischemic BRVO with macular edema. So you can see in the fluorescein in A and B, the microaneurysms definitely pop out at you. They light up like light bulbs, but everything else is a little bit murky due to the fluid, the edema in the area. Whereas the OCTA, seen in this 6x6 and then 3x3 scan of the macula, is not clouded at all, very high resolution despite the fluid. So we can really appreciate well areas of capillary non-perfusion seen as these areas of dropout. You can also see that the foveal avascular zone itself is very irregular. I do want to mention artifacts just because that's still a huge issue with OCTA at the present moment. So any attenuation to the signal, such as a cataract, vitreous hemorrhage, or even a dense floater, as shown here, will cause shadowing to the underlying vasculature. Projection artifacts are also a huge issue. It's probably the #1 thing to be aware of. So any vessels from an overlying layer can shadow down and project to underlying segmentation. So you can see here that the choriocapillaris segment shown in B, we were still able to see those major vessel branches from above. So it's important to really look at every layer when you see abnormal vasculature and make sure it's not just coming from an overlying segment. Motion artifacts are something to be aware of because the OCTA interprets any motion as blood flow. So we'll have a hyperintensity or white line shown if the patient loses fixation. And these scans do take a bit longer than typical OCT scans. So it's about 6 seconds to acquire that scan and does require some steady fixation. And then we also can get blink artifacts, of course, and that will show up as attenuations or black lines in the signal. So let's look at some examples of OCTA being utilized in specific conditions. Definitely, I would say the most useful utilization so far is in evaluation of diabetic retinopathy. So it's really exciting that we're finally able to visualize ischemia without running a fluorescein. We also can potentially see vascular changes in diabetic eyes before they're even visible fundoscopically. So as I already showed, we're able to easily see capillary non-perfusion, seen as just those dark areas where no blood flow is seen. We can also differentiate between any abnormal IRMA collaterals and true NEO by localizing exactly where the blood vessels are seen. So we know if it's an intraretinal location, it's not neovascularization. We're also able to monitor patients over time. We know that with increasing macular ischemia, we get an increased size to the foveal avascular zone. And we can also monitor these patients quantitatively, looking at their macular capillary perfusion density. And this is a patient. This is a 45-year-old female, type 2 diabetic for 13 years. Her BCVA is still 20/20 in this eye, but she has mild NPDR, and you can appreciate some irregularity to the borders of her foveal avascular zone here. And we can even measure the width or guesstimate it with our caliper tool. And so I was getting it at about 850 micrometers, which is definitely larger than the average FAZ. Just another image comparing, so this is a normal eye in figure A with a healthy FAZ. It almost looks like a nice spider web appearance with very even borders. And then B and C are showing two different diabetic eyes. The areas of capillary dropout are flagged by those asterisks. And then we can see some vascular remodeling that's shown with the arrows. And it is interesting to note that both for patient B and C, no clinical retinopathy was evident when these images were taken. We're also able to flag now with developments in the OCTA software. We can automatically flag the FAZ, so we can quickly look at the size and the shape. And through Zeiss, this is known as the angioplex metrics. There's a similar software available with OptoView, and there's also a change analysis component to this. So we're able to, again, easily monitor patients over time in a new way. I thought this image was really cool. Here, this study looked through OptoView OCTA to create color-coded vascular perfusion maps. So we're able to see that with an increase in the diabetic retinopathy severity, we can clearly see that we're getting a less and less dense vascular component to the macula. Age-related macular degeneration, I would definitely say the consensus seems to be it's a little bit less helpful for AMD compared to diabetic retinopathy, but we are able to use OCTA to detect those small CNVs that might have otherwise been missed. Currently, though, we're still having to manually go through and search for any abnormal vessels, so it is a bit tedious. It can also help us to differentiate just the large PED from actual choroidal neovascularization. But the big thing for AMD is to be very wary of artifacts, because with AMD comes drusen, and so oftentimes we're pushing up on those overlying retinal layers, so the OCTA is registering certain layers in different places than they actually are. So this figure is showing an example of that, where we have this large drusen where the avascular layer is picking up on a little signal shown by the white arrow. So you might at first think, is this NEO? But it's really just that signal coming from an underlying layer being pushed up into the avascular zone. So again, just comparing layer by layer can help to determine, is this artifact or is this NEO? Another thing that can be helpful is looking at the flow. So here is an example of a type 1 CNV. So we're able to easily localize and categorize choroidal neo as well with OCTA. But you can see that the corresponding B-scan shows high flow in the area of the CNV. And so this was a patient that I saw an 84-year-old white male. He's had dry AMD for 14 years and has really large, soft, coalesced drusen and pigment clumping. And so when we ran his HD 21-line raster, you can definitely see that this large PED with those intraretinal cystic changes are very concerning for neovascularization. And so looking at his OCTA, I was able to review this with a visiting retina fellow that day. And by seeing that there was very low flow in the area corresponding to the PED, we could conclude that this was likely not neovascularization. So instead of sending the patient right away for a fluorescein, he was being monitored at retina in 3 months. I'll just briefly mention as well macular telangiectasia type 2. So we know this is a bilateral condition of unknown etiology, but it involves developing abnormal dilated vessels in the juxtafoveal area of the macula. And so OCTA has been found to correlate very well with fluorescein angiography. As you can see over in the figure to the right, those dilated abnormal vessels seen just temporal to the fovea can be reproduced with OCTA as well. One of the capillary networks that we really could never see with fluorescein is the radial parapapillary capillaries. So these are still branching off of the central retinal artery, but they're going more superficially into the nerve fiber layer. You can see in the comparison picture here that in the FA, you're really not seeing much of that fine detail, whereas in the OCTA, we easily see all of the parapapillary capillaries surrounding the nerve. So in evaluating optic nerve diseases like glaucoma, we can now look at capillary density in addition to nerve fiber layer density. And this is just an example of the what's called the angiodisc scan through OptoView that's allowing us to analyze those radial parapapillary capillaries. But what do we know so far about glaucoma and OCTA? GIA was the first in 2014 to demonstrate optic nerve perfusion in glaucoma using OCTA. And they found that the optic disc flow index was reduced by 25% in glaucoma compared to normal eyes in the study. They also found a high correlation with flow and pattern standard deviation on a visual field. Chen et al. In 2016 showed that reduced parapapillary blood flux was comparable to RNFL thickness in glaucoma and glaucoma suspects. However, in 2017, Rao et al. Found that standard parameters like RNFL thickness or ganglion cell complex had better diagnostic abilities than the vessel densities did in eyes with glaucoma. But later that same year, it was determined that vessel densities seemed to have stronger association with visual field parameters than did RNFL thicknesses. So there's lots of conflicting evidence right now. It's still unclear. One of the major questions is kind of a chicken or the egg situation where are the vascular changes causing the nerve damage, or are the structural changes causing the vascular insufficiency? So we still need a lot of longitudinal studies to kind of make sense of all this data and know how OCT parameters can fit into glaucoma management. But this image is showing just how well correlated this all can be. So looking over the radial parapapillary capillary, or RPC segment, shows with a green arrow, it almost looks like a wedge defect, but this is just capillary dropout inferior temporal to the nerve. And you can see how well it correlates with nerve fiber layer thinning on our traditional nerve OCT to the right. And here we have another vessel density map, this time of the nerve fiber layer, also again calculated through OptoView images. So we can see that with an increase in glaucoma severity, we get a decrease in our vessel density around the nerve. So looking ahead, there's still a lot of developments to be seen. Flep source OCTA will likely eventually replace our spectral domain as the newest technology. So with that, it's using a longer wavelength light to get higher quality images and even faster image acquisition time, and also better penetration into those deeper layers like the RPE and the choroid. There's a lot of developments we need with OCTA software. So right now we don't have any normative database to quickly determine, is this level of vascular perfusion normal or abnormal? And we're also still manually searching through to look for any neovascularization. Another huge thing we need to do is kind of standardize all of the different OCTA instruments. So right now, those preset segmentations are a little bit different depending on the instrument. So to be clinically useful, we really will have to standardize those across the board. Anterior segment OCT is also going to be a thing of the future. So we'll be able to better understand things like limbal stem cell deficiency, graft rejection, and also look at lab evaluation and MVI. So that's exciting as well. So that was all very, very fast, but in conclusion, OCTA is definitely not a replacement for fluorescein. We're still not able to, appreciate flow and leakage like we can with fluorescein, but it does add a high resolution 3D picture to our information set. And really the most helpful place it falls right now is with evaluation of diabetic retinopathy. But into the future, we'll likely see new parameters for glaucoma evaluation and diagnosis as well. But currently, artifacts continue to pose a challenge. We need some software development and development of normative database. But with more longitudinal studies, this is a very promising new technology. So now I will hand it back over to Dr. Taub.
Thank you so much. Today, we're going to be talking about traumatic brain injury. My goal today is to discuss all of the different approaches. Let me see. Hold on. There we go. My goal today is to talk to you a little bit about brain injury and talk about all of the different approaches that we have at our disposal. I am the Chief of Vision Therapy and Rehabilitation. I get to work with an amazing team of doctors at the Southern College of Optometry. Let me keep going here. Again, my goal today is what the talk is going to be is we're going to really focus on all of the different treatment options that we have at our disposal. As I said, I'm lucky enough to work with an amazing team. We see both patients at the rehabilitation facilities themselves, as well as back at our clinic. Of our approximate 200 patients per week, about 30 or 40 are patients who have suffered either an acquired traumatic brain injury or a stroke. So where have these patients been, and why all of a sudden are we seeing an influx? And this is not just at Southern College of Optometry, but this is in clinics in colleges of optometry all over. So really until about the 1980s, we really just weren't seeing these patients. Think about the reasons why. The main reason why is that, unfortunately, they passed away due to modern medicine, medications, as well as technology such as airbags, different braking systems, helmets for concussion, and so forth. These patients are now living longer. And these patients, just like everybody else, they want to live their life to the best and highest quality of life. So they come to us through many different means, different ways, and our job is to really try to put them back together again to let them live to the highest quality. So now we're getting involved in these patients earlier and earlier. As I said, we see at SCO, we see patients both at the rehab facility, and there are 4 doctors that we get to work with, that I get to work with, who are actually credentialed at rehab facilities. One is literally about 100 feet from our door, and we're on an on-call system with them. As patients get brought into the rehab facility, and either the occupational therapists, the hospitalists, the medical professionals identify an issue, we have a staff member who really is kind of the quarterback, reaches out to the doctors, and we generally see patients within 72 hours. The highlight is really getting to work with all of the different professionals. So the amount of interprofessional care is tremendous. We try our best to take students as well as 2 or 3 of our residents in pediatrics, vision therapy, as well as traumatic brain injury with us. And certainly early on, they're watching us do the care, but then as time goes, they're actually performing the care and taking over, and the doctors are really doing kind of the scribing for them. So it's a role reversal. So what are some of the symptoms that these patients may be coming in with? When we enter the rehab facility, and I'm going to start with the rehab facility kind of as the main stage. When we enter the room in the rehab facility, we often don't have a tremendous amount of information. Patients can be complaining of blurry vision for a multitude of reasons. A huge complaint is double vision, and the double vision may be very noticeable to the patient. They may have complained previously, and we may walk in and the patient is wearing a black patch. There could be a sudden loss of vision. That could be a hemianopic field loss. It could be a complete loss of vision in one eye. It depends on the location of the injury. It could be a quad defect, as you'll see coming up. Because these patients are seeing occupational therapists, physical therapists, speech language pathologists, cognitive therapists, there's a lot of movement going on. So one of the other main complaints is the patient may be bumping into things. This could be coming from visual inattention, could be neglect as well. Big complaint is often dizziness, and you'll see I have a patient coming up later whose main complaint was dizziness. So what are all of the treatments at our disposal? As you'll see in the slide here, the top of the list is the correction of refractive error. That's not necessarily something that we'll often do at the rehab facility, mainly because our goal at the rehab facility is to stabilize the patient. Patients often have 7 to 10 days of working with the therapists, and if they're complaining of double vision and the therapist asks them to do an activity, it certainly is much more efficient and a higher quality activity if they only see one. So our job is really stabilization. With the turnaround in glasses, it's often not feasible to get them glasses very quickly. But in the terms of the correction of the refractive error, we're not saying necessarily the best visual acuity, because that may, as with, we know with kids and binocular vision issues, sometimes the best visual acuity and highest level of prescription can interfere with the binocular vision system. A lot of these patients that we're seeing, remember that ABI can occur in any population, any age population. Certainly with sports injuries, that's going to be younger kids. And CVA is, while typically patients are in the 50s and 60s, it's scary for me. I'm kind of in my low 40s when I start to see patients who are, in their late 30s and they're having strokes. So you have to be prepared for any age. Certainly those patients and younger patients may require near prescriptions as the accommodative system could be impacted. Prism is certainly at our disposal. I'll discuss a case in a little while. Different types of occlusion. We've got binasal occlusion and we've got spot occlusion. And then of course we have vision therapy. I do have surgery on the list that is something that we often, if we need to, if it's a muscle palsy or paresis, and we've gone through vision therapy and we're at a plateau. Very, very, very infrequent, but it is on the list. So I just want to highlight a few cases. So this is, honestly, this was my first vision therapy ABI case that I ever saw. And this patient is a 60-year-old white female. She had about 2 strokes in the 3 months prior to me seeing her. And she was actually referred by her nephew, who was a student, a fourth-year student at the time. She complained of having to turn her head to the left to see midline, and she could only read for short periods of time. She was actually either a lawyer or a CPA, so reading was very important for her. Her private optometrist had not referred her for any further treatment, which is really sad. So this was her visual field, and you'll see here that this is a Humphrey visual field. I certainly, you can see this is in 2009. These days, Humphrey visual fields for patients who have traumatic brain injury, I think are very limited. I prefer a Goldman visual field, gives much better control and much better feedback. And luckily, we've got several people here who can do that. And most of you guys, hopefully, at the different institutions have the availability of doing a Goldman field. And you can see we have a generalized constriction. Now, one of the important things that I learned in this case, and you'll see coming up, is back when I was in school, I guess maybe I had the impression, or I was taught, that the visual field is pretty static once there's loss. And that definitely is not true, 15, 20 years later. The concept of neuroplasticity is at the forefront of everything that we do in vision therapy. So what we did was diagnosed her with a saccadic eye dysfunction. You saw the visual field defect. She had a convergence insufficiency now that was not there previous. She had an intermittent alternating exotropia, and her visual processing was normal. We gave her best corrected glasses at distance and near. In terms of glasses prescription, one of the first things that we do for our ABI patients is to get them out of bifocals, whether it be a flat top or a progressive, giving them the widest field of view, and taking away any opportunity for visual confusion is going to be key. Yes, they do have to take their glasses on and off, but it's super important to give them that field of view. Our goals were to improve visual attention, improve those jumpy eye movements, and improve overall binocular vision. So what is our goal in vision therapy? Our goal is just like every other patient, whether it be a 5-year-old or a 25-year-old, to reduce effort necessary to process visual information, improve accuracy, and flexibility of the visual system. And vision therapy is the same core concepts as any other patient. There are specific activities in a sequence, and everybody, honestly, there are many ways to do vision therapy. If you got 10 doctors in a room, they're all going to have slightly different approaches, but they're all going to start at the same point and generally end at the same point. So I don't really want to focus on what I did in vision therapy. I'm just really going to say that I did vision therapy. So in 12 sessions, we had estimated about 16 to 20. You'll see the visual field changes significantly reduced. The saccadic eye dysfunction was significantly reduced. And while she had an intermittent alternating exotropia and reduced stereopsis prior, after she had a low exophoria and improved stereopsis. So here is the visual field about a year later. And you can see what's right on the right side. You can see what's left is this kind of incongruous kind of quad defect. And that ended up being the true visual field defect. She was able to read, and her life was significantly improved. This next case, here we go, we've got to get this video going. So this, we're going to show this video, and I may ask to show it again. So this individual, this was a 16-year-old female, and at the time was by far my youngest patient that I ever saw. And I kind of call her, back from the dead. She was in a car doing what she wasn't supposed to do at a time of the night that she wasn't supposed to do it. And unfortunately, she paid the price. She was in a coma, and the first time I got to see her, she was just coming out of the coma. About 2 or 3 weeks after that, and I was called in to see this patient with one of my residents at the time, Dr. Tina Esposito, who's at the Arizona College of Optometry now, it was a very hard case. We were able to give some minimal information as to what the patient was seeing. She had an eye turn, she had a ptosis, and pretty much told them that, you know, here's what we're seeing.
Apologies, Dr. Taub, you may be muted.
I'm back. Sorry about that. When the video went off, it must have muted me back again. I don't know where I got muted. So we saw her the first time, and she gave that information, and we saw her about 6 weeks later, and specifically we said, well, we would love to do some therapy with her. And Dad specifically said, well, you know, why can't we do the therapy here? So we actually started doing vision therapy in the rehab center. This patient is essentially nonverbal, and you can see that there's severe limitations in movement. So we were able to, you know, really start with basic eye movements. We had a whiteboard, and we started doing basic eye movements with different colors, different shapes, really working towards the skills that she needed, which were moving her eyes. And it was an absolute amazing experience. Get my next slide here. You can see this was about a year into her therapy. Her visual field, the top, and then several months later, you can see just the vast improvement in her abilities to pay attention and to identify the visual stimulus. So essentially, her visual field is completely normal. What's most amazing is her art. She was very into videos and video editing, and this is actually art that she does. And she's most amazing in that, you know, she's only able to use one side of her body. She actually does the art with one hand, and when she completes it, she flips it around and completes the art upside down, which is just absolutely amazing. So she taught me to never doubt what we can do for patients, and she's going to be in vision therapy for a long time. But as long as she continues to improve and her goals are being met, we're going to keep doing that therapy. This was one of my most recent patients. The other population we see is patients that are post-surgical removal of tumors. So she, during her surgery, this is a 56-year-old female, she complained of ptosis and double vision, which you can see in the picture. And during the exam, we noticed the ptosis, and we noticed that her pupils were, on her left side, were smaller in the light and the dark. She did have full range of motion in both eyes. And again, complaining of double vision. So certainly in the rehab center, really our goal was really just to give information. Because of the ptosis, she was not seeing double. So our goal, get her to therapy. I'm not going to focus on the disease portion of the case, but really our goal is, once we saw her in the therapy room, the ptosis was starting to resolve, and now she was having double vision more often. This is called a VO star. This is done on a standing gyroscope, and you have in the top right, you see the VO star. You can see that the left side there was certainly higher than the right. So our goal, in getting her to see single is to, of course, make it single. So you can see on the bottom left, we use 4 base down prism on the left eye. And on the bottom right, they're about equal in up and down, vertical. Certainly the right eye is much more disorganized versus the left, but that's something that we were going to work on in therapy. This patient is in a therapy program right now, and she's progressing nicely. When we work with prism, certainly very early on, until we have a plateau, we don't want to grind in prism. So we're going to really focus on using Fresnel prism. For all those who are not familiar with Fresnel prism, it's kind of like a stick-on prism, and you can cut it to either half of a lens, any shape you really desire. The beautiful thing is it's not permanent, and you can change it as the patient's visual system adapts and changes. Two more little cases here. This is a patient who is complaining of dizziness, and every time she would move her head, her vision would swim. So we ended up using a treatment called binasal occlusion. Binasal occlusion essentially reduces the duplicity of the visual field, removing that double in the middle. So this patient, you can see that the amount of binasal occlusion was pretty significant. For her, it needed more and more and more. We started with a small amount, and then further and further and further towards the pupils. So this actually goes towards pretty much the pupils. And as soon as we got this amount of binasal occlusion on her, all of a sudden, her head movements were much more stable. She was able to, over the next few weeks, really start to function properly in the rehab facility. She eventually came into our therapy department and started doing traditional vision therapy. How long will we use binasal occlusion? Really, there's no answer for that. It's very patient dependent. Some patients, we can reduce it within several days. Other patients may take several weeks to several months. When all else fails, spot occlusion. For those doctors who do vision therapy, the black patches is kind of the evil black patch. We don't ever want to see that being used in our therapy rooms, and certainly for patients who were aiming to get binocular vision back for. So this gentleman had a sixth nerve palsy, and I could not do anything in the rehab facility to get him to see signal. He just didn't, we just couldn't put him together. And some patients very early on have that issue. So for him to be stable during his therapy, we use some spot occlusion. And you can see that actually there are several pieces of tape on there. So we start with the smallest amount possible, and then we expanded it just a little bit. And I've done spot occlusion where it's a square. I've done a strip of occlusion straight down the center. I certainly know patients who have needed spot or occlusion superiorly on one eye, inferiorly on the other. You really just have to kind of go with what you need for that single patient. This patient was seen at our rehab facility, at our college several weeks later. We were actually able to get him into Prism using Fresnel Prism. And then several months after that, he actually didn't need Prism anymore, and he was just doing traditional therapy. So you can see that in the cases that I've presented, that there are a tremendous number of options. And my goal today wasn't to teach you how to do any of these specific things. Really, all of us have wonderful therapy departments at our disposal. My goal was to educate you on what they're doing, hopefully, because they're doing great work, and just to identify what they can do for your patients. Now I'm going to hand it over. Thank you so much. I'm going to hand it over to Dr. Klemenczyk.
All right, so thanks, Dr. Taub, and thank you to all of our speakers for their presentations. We do have a few questions coming in, so I'm going to take this time to go ahead and direct some of the questions that have come in to the speakers. If you want, also, these few minutes that we have can also be used as a stretch break in between sessions. If you have other questions, you can certainly use the question box on the webinar control panel to type in any other questions you have for our presenters. So I'm going to start here kind of in the order that they came in. So we have Dr. Spores, and he, first of all, for Dr. Morrison, says thank you so much for the update and for the presentation on myopia control. And he has two questions. The first question he has is just about randomized controlled trials and the efficacy of atropine in myopia control. I know you mentioned this in your presentation. Can you clarify for us just if there are any controls, and if they are out there, what they have shown?
Yeah, so just to clarify, basically what I was trying to say is that there definitely are randomized clinical trials that do show the efficacy. But the whole kind of point was that there are limitations currently, things like the length of time for the studies, and there really is kind of a discrepancy, and we're still working towards showing a clear correlation between refractive change and axial length. I know that there are a couple studies that have come out that do look at axial length, but really the work is still in progress in a lot of these studies. Does that answer that question?
Thank you so much. And then his other question was about over-minusing myopic children as a viable option for myopia control. And are there studies that discuss that as an option?
And thank you so much, Dr. Spors, for asking this to clarify this. So really, definitely not over-minusing as a myopia control treatment. It was more to achieve the optic that we need through a multifocal contact lens for clear central vision. And this is not fully understood. No, there's no study that really shows the mechanism for this. And actually, we do know that the opposite evidence actually exists. So we know that over-minusing or under-minusing is actually shown to have an effect on the axial length of the eye. And so this has been looked at more in spectacle studies. But yeah, so really what the point of that was just to communicate that in a clinical practice, and this happens with me all the time, oftentimes I'll have to give an extra click or two of minus at the minimum to be able to achieve clear central vision. And that's especially important, I find, in older adolescents. So, you know, kids that are starting to be able to report a little bit of blur through their multifocal, sometimes it's necessary to give them a little bit of extra minus, and especially in the higher minus prescriptions, with that multifocal, it'll help to achieve better vision in the distance for the kids.
Great, thank you. And Dr. Spors says thank you as well. And then we do have a couple more questions, Dr. Morrison, kind of just asking more just about fundamental questions, and they have in quotation causes of myopia progression. The questions are, is it a trigger caused by existing defocus, or is it vergence reaching the retina?
Okay, so I think what this question, I am kind of seeing all of the pieces of the question, and essentially the answer to that is we really don't actually fully understand the exact mechanism, and the defocus is really a theory. And so the reason that we kind of touched on that a little bit in this part of the program was because contact lens treatments for myopia control would utilize that as the fundamental kind of theory for how it works. And so the trigger, I'm not sure if that answers the question fully, but my answer for that is that we don't fully understand that mechanism, and that the defocus is just a theory that helps to explain it.
Great, thank you so much. My next set of questions, or my next question is for Dr. Taub.
Yep, I'm ready.
Great. So Dr. T is asking, what do you do for patients who you remove from bifocals and PALs, yet they would like a pair of glasses for distance and near? So more, have you found accommodative relief lenses like the Eisen effective in these patients?
To be honest with you, I put them in two separate pairs of glasses, one for distance and one for near. I find any visual confusion to just make the problem worse. So I want to remove any barriers to single clear binocular vision. So I'll go with two separate pairs of glasses. I won't go with any of the more complicated, fancier lenses. I'll go back old school.
All right, thank you. And then we have just one more comment that came through from Dr. Winters, and then we're going to move on just for time's sake. Dr. Winters said, thank you very much, Dr. Squire, for the update. And it said that you had mentioned that many of the visually impaired apps are first released on Apple, but she did want to mention that many of the apps in the presentation are also available now on the Android as well. And it says at least on the Samsung that she owns. So
yes,
that's a good.
They have become more available. I think that a lot of apps start out on the smartphone, but they have become more available. And I tried to keep everything updated, but there were probably a couple that kind of slipped through.
Oh no, and I know how that goes. Even just the technology is, there's updates coming through constantly. So thank you to everyone. And then I'm going to go ahead and move on here. If you have any questions about items our speakers have presented after the fact, please feel free to contact them. The speakers have provided their contact information, which you can see here. A reminder at the end of the event as well, we will be sending out a SurveyMonkey evaluation link, so please take the survey to give us some feedback. This does conclude our session 1. I will hand it over to Dr. Pence from Indiana University School of Optometry, our moderator for session 2.
Thank you, Stephanie. Also, let me take just a moment to thank Stephanie for Dr. Klemenczyk for her leadership in chairing the planning group for this online forum this year. She's done a wonderful job. Our next session, we're going to talk about assessing clinical professionalism. We have a series of panelists who are going to help us through this topic. Our panelists will be Dr. Eric Mothersbaugh from Illinois College of Optometry, Dr. Don Kwok from Pennsylvania College of Optometry at Salus, Dr. Eric Wu from the Chicago College of Optometry. Unlike our first session, which was very much lecture-based format, we would like this to be a little bit more interactive during this session. So please find your questions area and participate with questions or comments as this presentation goes on. I'm going to start us off by turning it over to Dr. Mothersbaugh. Eric?
Thank you very much, Dr. Pence, and thanks everyone for letting me join this today.
For this portion of the presentation, what we're going to be shifting to is a topic that has to do with our interactions with our students in the clinic on that.
Oh, Dr. Mothersbaugh, my apologies. We're getting a little feedback from your microphone. Did something change on your side? The audio?
It did not. Let me...
Oh, that's better. Thank you.
Is that better?
Indeed.
Okay, thank you. So what we're going to do is hopefully, like Dr. Pence said, keep this as an interactive format, so feel free to ask questions throughout. What we're talking about is a topic that is, in some ways, the goal is straightforward. Professionalism is something that we all want, but it's very difficult to actually assess. So take bits and pieces of this that apply to you and your own institutions as you can, but realize that there isn't, as we said here, a one-size-fits-all solution for all of this. So as you'll see on the next slide here, we're going to break this down into roughly 3 components. One on simply assessing professionalism, another on education, what we're doing currently and what other theories are out there, and then a third piece on outcomes, goals, and consequences. So with that said, to kind of run point on our first category is going to be Dr. Kwok, but realize the 3 of us might all be interjecting throughout this piece. So Dr. Kwok.
Okay, thank you, Dr. Mothersbaugh. So I will be talking about assessing clinical professionalism. And just to start, I do want to say that the 3 of us do not have advanced degrees or are experts in professionalism. We just spent some time reading the literature that is out there on professionalism, and that the 3 of us are extremely interested in professionalism. So some of the topics that we may bring up or talk about may be a little outside of the box or outside of the expectations, so please feel free to send us comments. But to start off, for assessing professionalism, before I move on to our survey results, I do want to say, well, why do we want to assess professionalism? Well, 1, patients expect doctors to be professional. In a study, compassionate care was the factor that most predicted patient willingness to return for or recommend to others that care. Additionally, internal surveys conducted at Mayo Clinic had similar results to other studies where they found high patient satisfaction and rating of quality of care are associated with physician caring, efficiency, listening, adequate explanations, thoroughness, and staff courtesy and teamwork. Additionally, professional societies expect professionalism to be taught and assessed, and professionalism is associated with improved medical outcomes, such as increased patient satisfaction and trust, increased patient adherence with treatments, increased likelihood that patients will stay with a physician, fewer patient complaints, and less patient litigation. Additionally, unprofessional behavior is associated with adverse medical outcomes, and that basically professionalism can be taught and learned and assessed. So by assessing professionalism, we are conveying the message that professionalism is important and valued, and that the assessment of professionalism can be used to enhance our students and practicing physicians to ensure that learners are attempting to master a subject that they know. Since we're all faculty, we know that in general, students don't try to master or learn the topics unless you test or assess them in some way. So I know in a lot of the literature that I read, they commonly said this phrase: they don't respect what you expect, they respect what you inspect. So students tend to try to master a subject or improve on a subject if they know they are being observed or assessed or evaluated for it. Clear expectations and rich experiences alone will not guarantee that professionalism is learned. So with that being said, Dr. Pence had sent out a questionnaire to all the different academic institutions. We received 15 questionnaires back. Of the 15, 94% of schools responded saying that they do assess professionalism in some way. The most common way is the 1 to 5 Likert type scale. The next common is 2 categories: acceptable versus not acceptable behavior. Additionally, we were a bit surprised, but we saw of the questionnaires that we received, 75% do not have a written rubric or guideline for assessment, and 94% do not have a specific professionalism evaluation form. Additionally, a statistic that is not on the slide is that 88% do not have a specific professionalism incident reporting form, and that 67% do not distribute a code of ethics defining professionalism or define professionalism behavior in a clinical setting. The majority of schools that responded saying that they do have a code of ethics, a majority of them have it in a clinic manual, so not necessarily visible or posted, and a majority of schools commented that they discuss clinical professionalism in their clinic orientation sessions, but we were surprised to see that not all schools indicated that they do discuss it in their clinic orientation sessions. So these numbers were a bit surprising to us. I mean, we were not surprised to see that 94% of schools do assess professionalism. However, we were surprised that not all of the schools have a written rubric or a guideline or specific incident forms or specific professionalism evaluation forms. Additionally, we found that 81% of respondents said that they do not ask staff to evaluate interns on professionalism, and 94% do not have peer evaluations of professionalism solicited. So for assessing professionalism, you know, what are some of the barriers that we may have? So this is a quote that we took from one of the articles that we read, where it says the inherent nature of grading or assessing professionalism is evasive because it is often hard to describe the presence or absence of theoretical traits and values to clinical scenarios. Additionally, professionalism is a subjective and abstract competency. I know when I was first asked to present on professionalism, I had to sit and think about, well, in what ways do I assess professionalism in my students? So I realized after talking to the 2 Erics that are on the panels with me that it could be difficult to just really vocalize like a reason why you would grade someone higher in professionalism. For example, at Salus we do use MetaTrack, and 2 of the categories that we assess our students on are ethics and professionalism. And I know that there's been times where myself or my colleagues have mentioned it to me too, where we have a student that did a good job on the exam. Like we felt we had a good interaction with the student was courteous, they presented fairly well, but then when I went to go grade them on their Metatrack, I had a hard time grading them up in categories such as efficiency, technical skills, diagnosis, assessment, clinical knowledge. So as a way to help, I guess, boost their grade, because I felt as if they did a good job, I would give them a higher score in ethics or professionalism. And as I reflect upon that, I thought, well, is this good feedback for the students? Because I don't have a concise, I don't have a concise comment to give the student to why I am giving them a better grade in professionalism or ethics. I'm just giving it to them because I thought they did a good job, but I couldn't give them a higher grade in, let's say, clinical knowledge. And as I've reflected upon just my own behavior of doing this, I realized that this could actually be a negative way of assessing the students, because the students will see a higher grade in, let's say, ethics or professionalism, but they may not understand why they received that higher grade. They may think, oh, well, maybe Dr. Kwok is really easy and she just gives that grade to most of us. And then it may be a way to almost belittle that category in the future. So I know for myself, I think that moving forward, I will, when I'm assessing professionalism and ethics, I'm going to only grade up if I see them showing like exemplary examples of professionalism. And so then that also leads me into asking the group, well, what are obvious examples of professional behavior? And what are obvious examples of unprofessional behavior? And then also, what are subtle examples of professional and unprofessional behavior?
So while we wait for a moment for anyone to put in comments and suggestions, feedback during your questions box, let me pose a question for Dr. Kwok and our other panelists. If we assume that there are a certain set of core competencies that we expect our graduates to graduate with, do you think professionalism is one of those core competencies?
Yes, I do. It's definitely a core competency because, as I mentioned earlier, it has been associated with patient satisfaction, improved medical outcomes. It's also expected of us from society and from our professional societies. Patients come seeing their doctors, trusting that their doctors will be professional, that they'll be honest and have good integrity and be able to communicate well with them.
And if we compare that to other core competencies, do you think we spend the same amount of time or we pay the same amount of attention to professionalism as we do other competencies?
I'll let you go, Eric.
Thanks. I definitely think it's something that we do not spend as much time on as other things. It's as we'll get into with some of the educational examples in the next piece. It's something that a lot of times the main way that it appears to be taught is by example, and that in some ways can be really effective, but in other ways it can beg the question: is the example that's being given always an effective one?
I think in the interest of time, we'll go ahead and move on to that next piece, which is the education on professionalism.
Okay, so let's advance to the next slide. So Eric is going to be talking on the education component. Eric?
Eric, you may still be muted. Apologies, folks. One moment. We just got to make sure of our panelists here connected.
So while we're waiting for Eric to connect to talk to us about education, let me just go back Okay, into the examples of professional and unprofessional behavior, just because some of the examples as a group that we came up with, I thought are fairly interesting, but obvious examples of professional behavior, of course, can include polite, respectful care in and outside of exam rooms, students stepping up to help one another out with patients, and just making positive, and also when you hear positive comments from patients about the students at the end of the exam. Eric, are you on with us?
Can you hear me now?
Yes.
All right, perfect. Sorry about that. So yeah, like we were saying before, we're not experts in educating professionalism necessarily, but we really want to take this opportunity for people out there that may have great examples that they've been using to educate professionalism, to hopefully share that with us and we can share with everybody else. The questionnaire that we distributed had some surprising results when we look at these numbers. I'm going to start with the lower amounts here. I wasn't too surprised with seeing that only a few of the institutions specifically do professionalism education in small group discussions as well as specific case presentations. I think a lot of times people, when they look at professionalism, they just assume that it's an obvious thing that has to be done, and that eventually students will just get it by the end of their educational career. I think a lot of people too also try to utilize a one-size-fits-all solution, whereas you can see a lot of people will utilize a professionalism talk per se in their orientation. When I look at that, I sometimes think, okay, if we're looking at professionalism aspects, a lot of us are looking at the clinical side of being professional while they're in clinic. There's obviously the idea of being a professional student and interacting with your colleagues, your classmates, and your faculty members appropriately as well. But if a lot of orientations focus on professionalism as a clinician, depending on your institution and how soon students get into the clinic, that might be too early. Students might forget some of the things that were brought up in that orientation. Not to mention, it's an exciting time for students. They've got a lot of other things on their mind. Professionalism talk may not be necessarily the thing that they remember. In fact, they'll probably be more interested in getting to know other people and then forget about those little tidbits here and there. Some other aspects that we were looking at was actual lectures on professionalism. It looked like a decent amount of people or institutions had portions scattered throughout. And so the question is, and obviously the questionnaire wasn't as detailed enough to necessarily point this out, but how in-depth are those actual lectures in terms of professionalism? When you get down to that, there's a lot of questions that each institution has to think about. Is there enough time in the curriculum to include professionalism? Obviously, everyone wants their students to pass boards. The other thing would be FTE issues for faculty. If they're in a course, do they have enough time for them to include those professionalism aspects? Or if they're teaching a separate course, do they have time in their workload? The other aspect that we want to think about is the format that we're actually using engaging with the students? If someone's just lecturing, which ironically we are to you, about professionalism, does it keep people involved, and is it something that they will actually take away because they were engaged in it? The last aspect from this questionnaire that we thought was really interesting was that everybody that did respond that they teach professionalism was that they model by clinical faculty. On the next slide, we want to look at all the areas that we would hope that people are modeling, but I think modeling alone can be a little difficult to hit all these aspects in terms of what professionalism is. This article here basically gave this definition of professionalism as a mixture of components. So they talk about foundational aspects, some pillars, and all of that comes up to make one big professionalism conglomeration. So each of the foundations are pretty obvious. Clinical competence is something that we all want to obviously have. Our main goals are usually to create good clinicians. So that seems pretty obvious. You have to be good at what you do to be a professional in optometry. Good communication skills is also pretty obvious. We're obviously in a profession that involves a lot of communication with our patients. And so a lot of that is focused on pretty easily. And then, of course, sound understanding of ethics. This kind of relates to the optometric oath, going over that, which we all have to, understanding our duty to care, but even things like understanding medical futility, where the students have to be taught that some patients, they may want certain treatments, but they may not actually end up being helpful. Is this something that you're going to choose to do or not do? From those foundational aspects, there's the pillars to professionalism. Accountability is really looking at responsibility for actions and behaviors. Clearly, we want our students to have that sort of trait. Altruism, probably something that a lot of people may not necessarily educate directly to, but you have to remember that the students should know that it's always in their patient's interest and not what is good for your pocketbook. Excellence is really referring to an optometrist's commitment to learning and improving, which is obviously reinforced with continuing education. And then humanism. This is the compassion, empathy, and respect that we want all optometrists to have for our patients. To top it all off is the capstone of professionalism. And according to this article, we need to encompass all these areas. So understandably, with so many areas that we're expected to meet in terms of professionalism, it's understandably difficult to ensure that the students are not only educated in these areas, but meet them at some sort of minimum level that may or may not be accessible. So on this next slide of educating professionalism, we have some questions on whether or not, on how we demonstrate professional behavior. When I go back to the questionnaire survey, 100% said they educate based on faculty modeling. We like to call this the hidden curriculum. It is obvious to some people that what they do is easily picked up by our students. There are some studies that found that role modeling is the most effective method in terms of teaching students how to be professional. It makes sense that if your faculty are acting in a certain way, that our students are going to assume that that's the appropriate way to act as well. So what we call the hidden curriculum is thinking about the faculty dress code. Things like ties, white coats, an appropriate interaction with students, just the comments that you make with students, whether it's in regards to didactic information or clinical information, or even as patients themselves. Some other things are arriving on time. If faculty are constantly 5 minutes late to their clinic sessions, then students will ultimately assume that being 5 minutes late is acceptable to them. So just want to reinforce that students usually will emulate whatever the faculty do. So we should all be aware of how we act and how we want the students to act as well. I'm going to move on to the next slide, and for time's sake. In case anyone has brought up any examples that I could have, please let us know. But I want to say the three of us, Eric, Joan, and I, we all graduated from the Illinois College of Optometry. So in terms of our formal education on professionalism, we all have a very similar exposure to that. That being said, we can't rely on just to the educational institutions to educate on professionalism and expect all of our students to follow that. I personally believe that there is aspects such as your upbringing, how your parents brought you up, or even geographical differences where certain ways that you act may be perfectly acceptable in one area and not in another. I think each institution as well teaches professionalism in a different way. A lot of that, as you can tell already, is because it's very subjective. There's not a very specific cut and dry way to be professional, and it's not cut and dry as to what people perceive as professional. For example, at ICO, I feel like now that I've been through other institutions that our dress code was quite conservative, and there's nothing wrong with that. But when you go to a different institution and something as simple as stockings for women, some people it's a big issue and other people it isn't. So there's little examples like that we can see through our different institutions that make a difference between, or it shows the difference in how we learn what professionalism is, depending on where we learned it. The generational differences kind of comes down to that dress code again. The stockings is a good example, but nowadays you even hear a little bit more about ties. Ties on gentlemen, is that considered something that's professional? And I'm a little biased because I'm a little bit more conservative, and I think a tie is an appropriate thing that our male students should wear. But understandably, there are articles out there that even talk about how ties themselves are not very clean, they're not very hygienic, and that they should have no place in medical offices. So there's lots of ways that people can see the difference between 30 years ago, what they consider professional dress versus nowadays. Another aspect that is brought up more often is tattoos. Are tattoos something that's normal? Is there an appropriate tattoo that can be shown or not shown? There's also the stigma that some people have against tattoos that will determine whether or not they perceive showing a tattoo in a clinical setting as professional or not. So a lot of times there's just a lot of mix between what people consider professional and not, and choosing what to educate is difficult because everyone comes from such a different background. The last question I hear is how often and when should formal education occur? Again, I'm coming back to the survey results that we had. 64% presenting professionalism and orientation. Is that good? Is that too early? Is that not enough? Now, this questionnaire obviously doesn't.
Well, I think we may have lost Dr. Wu. Dr. Wu, thank you very much for your comments. At this point, maybe we'll move to Dr. Mothersbaugh.
I also want to just make a quick comment in the education section about the hidden curriculum. As Dr. Wu mentioned that 100% of schools use role modeling as a way to teach professionalism. So we are using ourselves or our faculty members to be the examples of what professionalism should appear or be in the clinical environment. But a question I have to pose, or just something to think about, is that, to piggyback on what Eric has said about, where did we learn professionalism, but then also how are we as faculty also assessed on our professionalism? Because if we are the role models for our students, not all, we're human beings, so there's definitely going to be times when we have lapses in professionalism. So are there just systems in play to ensure that the faculty themselves are not unintentionally demonstrating poor professionalism without them realizing? So are there evaluations out there among faculty members where maybe it's peer evaluations, also supervisor evaluations, or patient evaluations of the faculty members themselves that and on their professionalism? Additionally, I also want to make a comment that in one of our studies that we read, they did say that role modeling, and Eric mentioned this briefly, role modeling is a very powerful education tool, and that it can oftentimes undermine the didactic teaching that the students may have experienced for professionalism. So for example, let's say the students had a course in their first year on professionalism, and then in their second or third year clinic, they are in the clinic environment, and then they see their attendings not adhering to the different values that were presented to them as first years. Well, then those values that they learned in their first year will actually just go out the window, and then they will actually put more of a priority or an emphasis on what they are actually seeing in practice in the clinic environment. So it's just something for all of us to think about and reflect upon on ourselves on how we are demonstrating professionalism to our students. But let's move. I don't know, Eric, do you guys have any other comments to add on that?
I would just say I think that segue is really good into the next piece about outcomes and goals. This idea that we can something that we could probably all be more conscientious and aware of is that there may be ways in which in practice in the clinic we are, as you said, like effectively undermining the principles that are taught at different components, and it's something to be very cognizant of. The danger of normalizing certain behaviors that, if you sit back and really think about it, aren't necessarily the example that we want to be sending. So. Yeah, with that, let's move on to the next slide. There's basically two we wrote there the carrot or the stick, but two essential approaches to how we want to do this. Do we want to have this be essentially goals-based or professionalism for professionalism's sake, where do we want to try to make students aware of all of these data about the impact on positive patient outcomes with professional behavior? There was some suggestion earlier in the discussion, and maybe if you agree or disagree, you can say something about it in the comments, that to some extent experiences with students may suggest that if there isn't a consequence-based format, or for example, if you're not going to be punished for doing something wrong or rewarded for doing it well, the incentive might not be there for students to truly learn the lessons that we're trying to teach them. So it becomes a question of what really does work with the students, and again, there is no perfect solution, but probably a mixture of this goals-based and consequence-based approach is going to be more effective than falling completely into one court or the other. Being able to recognize and highlight acts of esteemed professionalism, while being conscious of what we talked about earlier, avoiding the problem with grade inflation in that area. I know part of my role at ICO is completing primary care evaluations for all the students we see, and I know I can say for sure anecdotally at our school that that's an area that tends to get inflated. Somehow all of the students are above average professionalism, which means either we're doing something really well, or more likely it means it's an area that we're inflating grades. So how do we find that balance, and how do we enforce professional behavior without in a way that's going to be effective and lasting? So let's move to the next slide. So essentially, we need to ask ourselves what our goal is. We talked about after the first session about considering professionalism to be one of these core competencies that we want our graduates to walk across the stage and go into their practices with. But what does that really look like for us? I guess maybe Eric, if you want to, if you're with us and want to comment on this about students articulating what professionalism means.
Yeah, can you hear me?
Yes.
All right, perfect. I think, ultimately there should be a good mix between amount of subtle and not so subtle professionalism. The obvious ones are, like dress code. Obviously, if our patients are seeing our students or clinicians wearing, sloppy clothes or inappropriate clothing, that's an easy thing for us to fix. The subtle aspects, though, are really what makes the difference between most professionals out there. Little examples like, I wasn't able to know, I got a little disconnected, sorry, if this was brought across, but things like walking with your patient who has difficulties with mobility. Those are the aspects that people don't think about often, but are subtle and important for our patients to really appreciate the kind of care that we're giving them through professionalism. Obviously, we don't want anything unprofessional, but I think everybody's perception, again, of what's considered professional and unprofessional is still somewhat subjective.
Yeah, I totally agree. And on to that point, or I guess on the other hand, another thing that to be aware of, and this does play into the hidden curriculum component for us to all be cognizant of, is there are sometimes very subtle examples of unprofessionalism, and these are the types of behaviors that can be normalized. An example that comes to mind for me is with regard to deciding what an appropriate use of cell phone is. When is it okay to have them out? What is it okay to be doing with them? When, of course, there's generational components of that we could probably talk all afternoon about. But another subtle example is the type of conversation that goes on in these like conference rooms or back room settings where, sometimes behaviors that can be normalized that don't really reflect upon the values I think we're trying to teach are like subtle things about comments, like discriminatory about age, for example, or an off-the-cuff comment about somebody who's recovering from addiction, or anything that really isn't what we're trying to do, but can sometimes just seemingly happen. And that's the type of stuff that I think we need to be careful about on our end, both watching our own behaviors and also keeping an eye out for it amongst the students' behaviors, and knowing when it's appropriate to intervene and step up. So that I think does bring us to our next slide. The idea about what does constitute a violation? What is a behavior of a level of unprofessionalism that warrants intervention, and if that intervention is warranted, if it ever is, what type of punishment's appropriate. So I would say, just kind of from my own intuition, something like what I would judge to be an inappropriate use of a cell phone in front of a patient or something like that, I probably would intervene with a student, but not necessarily to the same level as I would if I heard somebody make a discriminatory comment in a conference room, for example. But I think that certainly this is something that does not get touched on in the evidence as much as we would like to, and I think it's one of those things where we know professional behavior when we see it, but some of these things are difficult to measure, and it's also a little bit unclear what the best way to implement consequences are. We know that we want it for sake of improving patient outcomes, but how to get it is a more challenging question.
And Eric, one of the interesting time, I think we're going to have to wrap that up at that point. If we can go to our next slides, go through one more, because I think we'll have little time. If you have questions and feedback that you'd like to give to any of our presenters, feel free to do that. We very much appreciate their willingness to participate in this. As sort of final comments, in looking at what the schools are doing and in talking to folks, as Eric said, we sort of are in the I know it when I see it mode, but I'm not sure that's where we should be. We should probably be doing it a little bit more deliberately and with a clearer definition. So hopefully one of the key take-homes from the session number 2 might be that we need to teach professionalism more deliberately and more consciously, to be more explicit in defining exactly what it is, and then to seek to find ways to give more effective and better feedback to interns on the topic of professionalism. So please give feedback to any of our presenters. At this point, we're going to take about a 5-minute stretch break, at which point we will come back in about 5 minutes.
Well, right, yeah. And even that.
So if we can begin to come back from our break, we will look forward to starting session number 3. So I'll give folks just a minute to get settled again. But also comment again that at the end of this program, we very much would like everyone to go to the SurveyMonkey website here and please fill out an evaluation. We very much want your evaluations and input. So the next session 3 will be moderated by Dr. Maria Parisi from Pennsylvania College of Optometry at Salus University. Dr. Parisi.
Good afternoon. I am the Associate Dean for the Optometric Clinical Affairs at Salus University, Pennsylvania College of Optometry. And for our final session, we will hear about clinical remediation from Dr. Kari Yoshiyama from the University of California, Berkeley School of Optometry. And now I will hand it over to Dr. Yoshiyama.
Good afternoon, everybody. Thank you all for being here for our last discussion. I'm honored to participate, and I think in the interest of time, I'm just going to jump right into it. The main topics that I'd like to talk about today are just an update on where we all are right now as a clinical profession, and to sort of discuss 5 basic topics, which are, number 1, how frequently we are currently evaluating our clinical optometry students. 2, what types of remediation are we currently offering? Number 3, remediation in learning disabilities or mental health concerns as it relates to clinical remediation. 4, some online grading and tracking tools that we might be able to use. I know a lot of us are currently using Metatrek as a grading platform, and I have worked with them fairly extensively to do some modifications. And lastly, to talk about going forward, how might we all tailor our remediation strategies to be most effective for our individual students. Completely. So again, I'm from UC Berkeley, and I'm currently the Assistant Clinic Director here, and I am in charge of much of the clinical curriculum development in the clinic and the remediation programs as well. So on the first topic, thank you all who have participated in the part 1 of a survey that I have sent out regarding clinical remediation. At the time that I submitted the slides for this talk today, 14 schools have participated, but we're up to 18 schools now, which I find is very inspiring. So thank you, all of you who have participated. And that 18 schools is really the majority of the schools, ASCO schools, who currently track and have access to remediation data for their clinical students. So I just want to point out, so for those of you newer institutions who may not yet have a number of years of remediation data, that we welcome you to join our discussion. And if I can be of any assistance going forward, please don't hesitate to reach out or ask any questions. So to answer the most simple questions regarding clinical remediation, we have to take a step back to how are we evaluating our students to come up with that particular diagnosis or designation of their challenging aspects of clinic. And so the first one is, how often do we actually evaluate our clinical students? And I think that you can see that the majority of us assess our students both at the midterm and at the end of the clinical terms.
But I'm always really inspired and awed by those institutions. You can see 36%, or over a third of the respondents to the survey actually evaluate their clinical students after the end of any clinic day, and some of them even after every patient encounter. And so, I think we can all agree that the most that we can provide our students with feedback, the better responses hopefully that we're going to get. And I think that a little bit of that is tailored to how our particular clinics are set up. But at some point, I would love to speak to those who are able to do a clinical evaluation after every encounter, because I think it's a really ambitious goal. And if we can all get to that place where we're evaluating our students very frequently and providing that feedback, I think we're doing a really good job. So the second thing that I looked at was when we do identify students in whatever method that the institution has designated as remedial, what kinds of remediation strategies are offered to our students. And across the 14 schools in this particular slide, I do want to point out that even with the addition of the additional 4 schools, almost all of the data was very similar in how the distributions actually present. So this is a fairly good example of how we are currently remediating our students. And the vast majority of us, 71%, are giving an extra day of quote-unquote regular clinic, meaning that in primary care type examination situations that we're giving the students the opportunity to participate in at least 1 or more additional days of that clinic to hopefully give them more experience and foundation to be successful going forward. And this is followed fairly closely by one-on-one clinical tutoring. So once we've sort of identified the students, setting them up in a mentorship situation with either a faculty member or sometimes even a senior student or a resident to give some, pretty specific one-on-one mentorship, and that's fantastic as well. The next one down, I was intrigued by, and it goes into what I'll start talking about in the next slide, is the next most prevalent form of remediation that we seem to be offering now is psychological counseling. So that is something that almost 40% of the responding schools have said that now they are offering some form of psychological counseling, whether on campus or off, to clinical students to help them with coping strategies and being able to integrate fully into their clinic experience. And that's very closely tied to the next one, which was providing an extra day, not of just regular or primary care clinic, but a special day of remedial clinic with a specific remediation instructor. And I sometimes employ that strategy at Berkeley. It does require some training of specific instructors that you think might be good mentors under certain situations, and I'll talk a little bit more about towards the end of the talk about some strategies for actually educating our clinical instructors to be the best clinical instructors that they can. And then the variety of the rest of them kind of span the distance, somewhere in the teens and 20s. Those include observation clinics, group tutoring, self-reflections, and of note, I think almost none of the schools offer no clinical remediation, so we're all doing a very good job with that. But the other thing that was interesting to me is in this age of technology, and a lot of our prior talks and speakers really illuminated how technology is our advocate and our ally in sort of the teaching of our patients and our students, that none of us currently who have responded are using any sort of online training. So that might be an area that we could expand into going forward. And as I alluded to previously, one of the things that I looked at in the survey was because we are seeing more instances of schools offering help in professional conduct and also mental health services and things like that, I polled everybody about whether or not we felt as a whole that the diagnosis of specific learning disabilities amongst our clinical students or mental health issues amongst our students were increasing over time. And this is the only slide that changed a little bit in terms of the percentages of students or schools that responded. When I added in the data from the additional 4 schools that participated, both of these numbers actually increased. So it increased to about 60% for the learning disabilities and closer to 70% for the mental health issues increasing. So I think that in addition to the traditional ways that we are helping in our strategies for remediation for our students, these may be things that we need to specifically take into consideration as we move forward to make sure that we are covering all aspects of a student's professional profile to help them be successful. So I'd like to move on to what kinds of online tracking or customizations to our grading platforms might be available to us so that we can actually have the goal of identifying students as early as possible and making sure that we don't lose students to follow-up in terms of keeping up with them when they go out onto rotations or if they're going into specialty clinics after their first year. So the first one, I think when I polled institutions, virtually everybody is currently using some form of online grading system, and of those, a majority of us are currently using Meditrek. So I thought I would share with you some of the customizations that I've worked with Meditrek over the years to develop that really have helped me in a glance identify which students overall are struggling and to see how they're progressing over time once we've initiated some sort of remediation strategy. So this first one here is the most basic, and I think a lot of you out there are probably already doing something just like this. Critical records is something that Meditrek does as part of its platform, and it's something that you can sort for a whole year, a term, or partial term for students. We have it set to sort by either remedial or honors so that we can also easily identify students who might be good candidates for scholarships or recognition of some sort. But in this particular case, we'll just be using the ones to sort for students who have come up for remedial. Meditrek does a really nice job of tying this to communication in that in real time, and I got one actually apropos earlier this morning, by sending an email out to the administrators that you designate for a critical record coming in. So anytime that an instructor submits online an evaluation that meets your criteria for remediation, it will actually send an email to an administrator, in our case is someone in the clinic administration office, so that we can review it immediately and take action as soon as possible. So I feel that that gives a nice spot check or on a daily basis where students are at any given moment. And what you can see when you do that and you click on, so I have sorted for fall 1 in this fictional scenario, and what it will show you very quickly is the number of students and the names of the students who have come up for that particular term with a remedial grade in sort of real time. And what at a glance this allows me to see is in this particular situation that there have been 3 students who have been identified here, but one of them has been identified twice, one by me and one by another mean instructor who has pointed out and given some feedback on some remediation. And what that allows us to do is to click on the name of the evaluator, and it will go directly, link directly to the student's evaluation so that you can read the written, not only see the grade, but also see the written comments by the instructors. And this is very useful if you're going to bring in students for an in-person meeting. to help corroborate, what the clinical instructors are letting you know. So, student X, we've had a couple things. Tell me what you think that is going on in your clinic and how you feel it's going and what you think could be going better. And you have a little bit of backup if you have multiple instructors who are pointing out some similar deficiencies in your students. Could you advance the slide, please?
Certainly. One moment. It seemed to have zoomed in a little bit. There we go.
Thank you. So the next one was the first one that I really asked them to customize, and Metatrek was really responsive to doing this. And so I was able to create an individual remedial grades report. And what I really wanted to see was, in addition to the daily points in time so I can see individual students and evaluations as they were coming in, I really wanted a quick way to check in with a whole class of students to see which among those students, if any, were struggling, so that I could reach out to them and their instructors to see if I could offer support to them early in a term, to see if we could make some course adjustments for the students in clinic, or initiate some early support for the clinical student in terms of mentoring or observations or tutoring or something like that before the actual final grades come in. And so in this particular situation, it's very simple. You just select the class that you'd like to look at, and then if you click on the for student at the bottom and you click on the drop-down menu, it will simply list the names of the students in that particular class who have ever received a remedial grade in any clinic. And you can set that for however you want. In our system, it flags any that have a grade of B- or lower. And then you can click on each one of those names in the drop-down menu, and it will bring you to another screen that will help you look at their entire clinical experience in a glance. The other reason that I really like this way of displaying the information is because I can very quickly scroll through year to year for the past 10 years and just look at the number of students that are being flagged as remedial. And it helps me to gain some information about trends that might be happening as we go on in the years. And so that's another thing that's been super helpful. Advanced slide. And so if you click on an individual student's name, this is the display that it will show you. And what I really like is the ability for us to see a couple things. One, this is a third-year student who had been struggling early on. And what it allows you to do is see very quickly that from progression from summer 1 to summer 2 to fall 1, that there's a trend downwards in the grade. So perhaps this is a student who started out sort of mid-pack or slightly lower, but is sort of slipping as the class as a whole is starting to progress and advance in their clinical proficiencies. And so what it also shows is how many days of clinic the student had, what types of clinics the student was assigned, and what days that they were assigned as well. The columns for us go Sunday through Saturday. We're a 7-day-a-week clinic. And what I'd like to point out for this one is that as soon as summer 2 started and we started to see the first remedial grade pop up, I met with the particular student and we agreed upon an action plan going forward. And you can see in fall 1, there's 6 days of clinic that are in there. We were able to insert the student into multiple days of clinic to give the most chance of success. One of those days, though it doesn't designate this, was an additional day of specific remediation clinic with a specific instructor and a specific action plan. And you can see that the grades in the fall one were still a little bit lower than we would have liked. And this is a good thing for us to look at as well. Did we overload this student in our ambitious effort to give them more clinical experience, because between summer and fall, their didactic load also increases? I will note that the BV clinic was not the whole term. So we're essentially talking about 5 continuous days of clinic for this particular student in primary care. But what it allows us to see is that when we evaluated again in fall 2, the student really made a significant improvement and continued that trend on to spring and ended up being incredibly successful in their 4th year and on to graduation. So I do like this as a way to see if students are progressing with the remediation strategies that we're using going forward. Please advance. And then a grading summary report. I'm sure every one of us has our own versions of our grading summary report that allows us to see what the grades are going to be at the end of every term. Advance slide. And for us, this allows us a gestalt of the overall remediation needs of a particular class. So I've only shown you 2 students in here, anonymized, but it would list, all 60 or 65 or 70 students that were in the class in a similar fashion. And what that allows me to see is, in a particular term, did we have more remedials than we typically have, and did they fall mostly on particular days? Because that might give us some information about certain clinics or changes in our clinical faculty where we might be able to reach out and sort of recalibrate or decide what has been going on in that particular clinic that is making it more challenging for students as well. Advance slide. And then I would also like to touch upon grading versus ranking systems and the ability that Metatrack has of doing both. So we all use our individual grading systems in our institutions to come up with our own rubrics on how we're going to determine our final grades. But Metatrack and other online platforms also have ways to do rankings of students. And sometimes this is a really nice counterbalance to perhaps differences in instructor grading trends. So we might all have some instructors who are really nice and whose grades tend to be a little bit on the higher side, and those that are in the middle, and maybe some who are more discriminatory and are challenging clinics to our students. And so we want to make sure that we are correctly identifying, the students that need help. And one of the ways that we can do that is by, in addition to the clinic grades that we are assigning, to either ask clinical instructors or perhaps your clinical didactic lab instructors before they get to clinic, or in some instances, mostly this is in medical schools and not in optometry schools, peer rankings, like if you had like a chief resident who was also evaluating the residents in a particular field. And these are really helpful, and I find that it really, by the end of the year, if you're doing this consistently, really counterbalances the different grading trends, and that if someone tends to grade high on the grading spectrum, they are still required then to rank the cohort of students that they might have, from 1 to 4, 1 to 3, however many that they might have. And at the end of the year, when that's tabulated, it gives a really good idea of the students who are struggling more than others. Advanced slide. So now that concludes part of what we are currently doing, or what easy changes that we could make to our tracking systems and our grading systems. I'd like to segue on into different types of remediation tools and what is most effective for our clinical students. And what I'd like to start with is some discussions about that I've had with Dr. Garofio, who is the head of the remediation department at the University of Colorado Medical School. And those of us who were at the ASCO clinic directors and externship meetings in the fall had the lovely experience of listening to her talk on the particular topic, and she was very gracious and spent some time over the phone discussing with me certain strategies that I would love to share with you. I will note that in her particular program, she has quite a bit of financial support and FTE support to develop the type of program that they have for their medical students, and we all might not have those same financial and time support systems in place. So this particular book that she puts out is currently available. She's going through another iteration of the book that should be out soon. The other one that I did want to point out is the Remediation in Medical Education textbook, a mid-course correction that we are all familiar with as well for Colette and Cho. I've read both of them, and they're wonderful resources. But when I was trying to develop what we might be doing for our remediation, it didn't fully help me understand how to build a remediation program and what resources that I would need to do that. And so, again, many thanks to Dr. Garasio for her time in speaking about that. And one of the major things that she put forth is that you need to dedicate some time and resources to it. So in her particular situation, she has a program directorship, and then FTE, she suggests somewhere between 20 and 50% FTE devoted to remediation, and then a cadre of remediation specialists that will be working with the program director at around 5% FTE, and also web-based tools and other services for the students. And so that's basically the medical model that she's put forward. But I wanted to talk about what things that we might start to be able to implement in our own programs currently. And I think the primary thing to consider is how we are assessing and reassessing our students. So I think the most important thing that we can do for our students is to have a very solid competency assessment. The second that a clinical instructor might identify a student to us, and then to diagnose the specific deficiency of that student, and that goes to the study that I have ongoing now that I'll touch on in just a moment. Then the development of a specific remediation strategy for that student. Giving them feedback and time for reflection, and then coming back and reassessing to see if what our tactics that we're employing are actually helpful. And so, advanced slide, please. So to reach our current clinical students in this generation, I think we all would agree that some of the mentoring that we are all finding ourselves doing is to instill the qualities of lifelong learning and personal responsibility, accepting and incorporating feedback, self-reflection, and the ability and flexibility to change. So how do we do that? And one of the ways that I have found that has been relatively successful in this generation of students is really by having written contracts. And so now I've switched over to having all of my orientation materials to clinic in written copy that they sign on their first orientation day. I developed a clinic contract for all of the students before they enter into clinic that they will all read and sign. And if your institution allows students to decline remediation, I would recommend having a specific declination form that they decline that could be put into their clinical file, so that if it ever comes up in the future, you have some reference that clinical remediation was offered. Advanced slides. Individualized remediation, I think that students and everybody, I think all of us included, respond very well to individualized remediation. One of the things in the interest of time that I wanted to point out is the second one, the self-reflection and guided modifications. I know in the last speakers spoke about professionalism and can we remediate professionalism. And I think that that ties in nicely to what I'm talking about. And whatever the case might be for the students, once we've identified what is the area of deficiency, what I've started to do was asking the students to write a very brief written assessment and self-reflection about a case that didn't go as well as they might have liked. And the first one I want to be free-form, just as the student perceives it. And then I give them some time to submit that, and I read it. And then I ask them to go back in a second time, and I ask them to write the same self-reflection, but with taking out all of the patient contributions to the problem examination. Basically, getting the students to work through how they could make their own situation go more smoothly the next time with the things that they could actually control in their examination. For instance, you can't control a patient being late or not maybe having access to or knowledge of their conditions or medications, but what can we do right now if we had that situation come up again that would make the examination run more smoothly. Advanced slide, please. So that brings me into how do we mentor our clinical educators to remediate. Like I said, there are many different strategies, but if we want to move into a modality where we're having more focused one-on-one type of remediation strategies, or maybe even having a specific remediation team that would go in and work with students specifically, we need to know how we might be able to mentor our clinical educators into helping our students. And some of the ways that we might do that, some of the things that we've started over here at Berkeley, is in the summer for the new third years coming in, we have shared summer seminar topics in a timeline. They have a 2-hour lunch break, and we give them a guideline that is not absolute, but that we suggest that they cover certain topics to make sure that the students are getting a somewhat even educational experience in the clinic. Dedicated clinical faculty meetings and training opportunities, vertical meetings. We had one yesterday with a clinical, didactic, and perhaps sometimes research faculty to see if we can align the teaching a little bit better so we can let them know how our students are doing and what things that we might be able to do to help them be better prepared for clinic. And periodic whole school faculty retreats, which are every 5 or 10 years there. So advanced slide, please. So I did want to go back and touch on some of the things that we might do. I think I spoke a little bit briefly about the ranking system so that we might address some inconsistencies in our clinical grading so that we are identifying our students appropriately and as early as possible. And so what I've kind of shown you is another tool that we've developed with Metatrack, which is actually something that tracks clinical educators' grading distributions. And this is not something that they look at all the time. It's something that we look at, but it allows us to look at different clinical grades and students and see what instructor they're matched with, so we can kind of gauge that. And periodically when we have those group faculty meetings or retreats, we can go over this data with the clinical instructors to let them know that, oh look, your grading distribution, it seems like it trends a little bit on the higher side, and we can give feedback about sort of what we expect the average distribution of clinical grades to look like. So you can see on the left is perhaps an instructor who grades a lot of students, but might grade a little bit on the higher side versus someone who has a similar number of students, but who might be a little bit more normalized in their distribution. And sometimes I'll reach out to instructors themselves and just show them their grading distributions to see if we can help them calibrate where we are. And this is particularly helpful for the newer clinical faculty as well. Advanced slide, please. So the last thing, so thank you all for your attention. The last thing that I did want to circle back to was the second half of the survey that I am planning to send out soon. And the reason that I haven't sent it out was because I actually got some really wonderful feedback from some of you out there. So thank you very much for that. As well as I got some feedback from Dr. Garasio about the study design. And one thing that I wanted to bring out was that what I'm planning to do is send out a survey to help us understand as optometry schools where our students are currently struggling. So the original survey included 4 basic categories, and those were A, technical skills and efficiency, B, knowledge base, 3, clinical reasoning, and D, interpersonal coping skills and professionalism. And Dr. Garcia was the first to point out that I might want to separate that into more granular discussions. And in her evaluation of her students, she actually broke it down into mental well-being, professionalism, communication, interpersonal skills, time management, organization, clinical reasoning, clinical skills, and knowledge. And for the scope of what we're doing, that's a little bit of a lot to ask people to go and individually look at their remedial students and parse that all out. But I was wondering, and I'm going to throw it out to the group as a whole, the number one thing that folks had concerns with the strategy of the 4 different ones was A, the technical skills and efficiency. Because a lot of folks out there, a lot of you felt that efficiency could be its own category because perhaps it was tied to a certain other type of deficiency, for instance, clinical reasoning. And so I'm just going to pose it to all of you, and you can get that to me by email. My email is right up there, or you can text it in to the moderators here today. Whether option 1, you feel like it would get better information for all of us to keep with the 4 different categories, or option 2, to expand it to 5 categories and separate technical skills and efficiency, making efficiency its own separate category. And with that, I'm concluded, and thank you so much for the honor of participating, and I'll open it up to any questions anyone might have.
Okay, we do have time for some questions. Please use the question box on the webinar control panel to type in any questions you have for our speakers. Well, right now I don't see any questions, additional questions. So if you have questions for Dr. Yoshiyama, I recommend you email her. Her contact information was provided. If you want to take that down, it's on the screen right now. Next slide, please. So we want to go to the SurveyMonkey link on the slide to give us feedback on this event. It's really important for us to have your feedback so that we can take this into consideration for next year's. And this concludes session 3. I will now hand it over to Dr. Baker to conclude our event.
Great, thank you. I'd like to thank all of our speakers for their time and expertise listed. Listed in the presentation here on this slide, you can see all of our presenters in the order of their presentation. I'd also like to extend a special thanks to the ASCO Clinic Directors and Administrators SIG for their generous support. Without their financial support, this event could not take place. Thank you to the CAC and the OCEF Chair and their planning group members. An additional thank you to Dr. Neil Pence, who's been involved in this Clinical Educators Forum since its inception in 2011, and has continued to provide the leadership for this program. Also, as I said at the beginning of the program, thanks to Carol and LaShawn, they've been the driving force to ensure the success of this program. The fact that this program took place is because they have kept us moving forward and worked out the technology. Our final reminders: if you are watching as a part of a group, it is critical. Please make sure that you have each attendee sign an attendance sheet, and then the institutional liaison should send the attendance sheet to Carol Brubaker at cbrubaker@opted.org. Also, please go to the SurveyMonkey and take our survey so we can assess what we've done today and utilize the information for future planning. Finally, this webinar will be made available for additional viewing through the ASCO YouTube channel. Look for it on our website soon. Thank you all for your participation today.